Good morning, everybody. Welcome to our webinar. We appreciate your flexibility in going remote as we were planning to do it in person. But it's my pleasure to introduce our first speaker of the day, very dynamic, Taya Moheiser. She's the Chief Revenue Cycle Officer at H4 Technology. This is a SaaS company focused in the healthcare industry. Taya received her executive MBA in healthcare management at Creighton University after building a strong career in healthcare management and revenue cycle consulting. Having held senior level executive management positions in private practices, collaborative institutes, and national care coordination organizations, Taya now educates and consults on all areas of healthcare operations. She is a member of the MGMA's Government Affairs Council. She's co-authored the MGMA publication, Revenue Cycle Management, Don't Get Lost in the Financial Maze, and is also a co-host of the Rev Dive podcast for revenue cycle leaders. Thank you, Taya. I turn it over to you for your presentation.
Thank you so much. And I have my camera on briefly just to say hi to everybody, but I'm going to turn it off just so that you can focus on the content. And also because I don't think you joined to see this lovely ponytail that I'm rocking today. So I'm going to go ahead and kick that off. A little bit of housekeeping before we start. The most important thing to me is that we have real great engagement in this session. So if you have questions, please put them in the Q&A or put them in the chat. Make sure that we can see them. I would love to address your questions right in the slide that you have the question about. Chances are, if you're brave enough to toss that question out there, there's somebody else that isn't. So please, please ask your questions. I'm happy to pause and answer them. All right, and with that, we'll go ahead and get started. So today what we're talking about is ways to evaluate and assess the revenue cycle with a focus on strategic improvement. And a lot of times when we talk about revenue cycle management, we talk about the things that have happened to us in the revenue cycle, right? Why are our denials increasing? Why are we seeing these claims come through and they're not as clean as they could be? So we're going to look at some ways to attack that from a preventive perspective, and we're going to look at the ways that technology can support us in that. And I'm also going to apologize that my voice is a little gravelly. I'm getting over the flu. If you need a copy of that bio, it's in here for you, but I am going to skip past because, again, that is not why you guys joined to chat today. So first, let's talk about strategic plans, right? I think that most of us have a corporate strategic plan, and we use that on a regular basis to assess, where we're going, where are we headed? What are we looking at doing long-term? What are going to be the activities that are required for us to reach our goals? How are we going to approach that and make sure that while we are trying to achieve these long-term goals, we're staying in alignment with who we are, right? With our mission, with our vision, with our values. And having these corporate strategic plans are normal, right? It's normal for us to have a roadmap of what we're planning to do with our organization. Today, we're going to be using key components of a regular corporate or organizational strategic plan and applying those to the revenue cycle model, because what you want to develop is your own strategic revenue cycle model work plan. When we talk about strategic RCM planning, keep in mind that this doesn't mean we need to have major changes, right? Having a strategy just means we have a plan. It doesn't necessarily mean we're looking at some sort of gigantic implementation of a big technology. Sometimes it just means we need to make sure we have a clear understanding of our strengths, of our weaknesses, of the areas that really matter and are impacting our revenue and our ability to capture that, right? The main focus is making sure that we are taking a look objectively and subjectively, evaluating what's happening and preventing anything we don't want to happen. And when we don't put these things into place, that's when we start to see that we have roadblocks potentially we created ourselves, or we have opportunities that we start to. And somebody is not on mute. So if somebody, whoever's entering their personal identification number, they could go on mute. That'd be awesome. Thanks.
Sorry about that.
Not to worry. All right. So In terms of your strategic plan, what we're really looking at, right? Those are just the ways that we are planning ahead. If any of you listen to like the Dave Ramsey method of telling your money where to go instead of looking for where it went, this is what we're talking about, right? When we look at a corporate plan and we apply it to revenue cycle, this is when we start to look at long-term direction. What is our long-term goals? We want to be financially solvent, right? We want to make sure that if we have areas we want to increase or providers that we want to hire or a new business model that we want to do that's going to require more care support or a new building, that we can achieve those business goals. The first step in being able to achieve any new goal, right, is to make sure that right now we are stable and we're on solid foundation. Your long-term direction should tie back to your corporate business plan, right? That landscape, that current environment that you have, you should make sure that your revenue cycle strategies are tying back to your organizational goals. And when it comes to core competencies, those are also going to look similar, but we want to make sure we're applying the RCM lens to that. What are the workforce abilities? What are our technological capabilities? What specialty are we in, and what core competencies in terms of coding do we need to know for that? Breaking core competencies down further into analysis and business goals should drive other questions. And whenever you're looking at your strategic plan, that's what you want to be doing, asking yourself questions. In that analysis phase, you should be asking, where are we right now? What are our gaps? What are our vulnerabilities, right? What are we not doing as well as we could be? And in terms of our business goals, do they align with our strategic plan? If our goal is to primarily reduce denials, does that align with the goals that we have on the business side of the fence, right? So we need to make sure that everything we're doing is mapping and in alignment with each other so we don't end up wondering what happened at the end of the year. Now, when we look at approach, this is your plan. This is where you're engaging everybody who is a stakeholder in the process, right? You want to really drive those actionable steps to achieve outcomes when you're outlining your activities. Your vision, that's where you're making sure you map to your mission and vision, right? This is separate from looking at your business goals that need to align to your strategic plan. What you're doing here is creating a double check. So if your corporate strategic plan aligns to your mission and vision, and you make sure that your revenue cycle management strategic plan, those business goals align, then when you go through to your approach and your vision, it should also align. If there's an issue in there and you see misalignment, that is your double check. That's something you need to go back through something and make sure that somewhere you didn't step off of your general path. Now, that's a lot of information. It sounds super high level, right? And you're like, okay, yeah, we know this is great in theory, but how do we really apply these things in feasible ways? I hear you. So let's dive into some of that. When we talk about the revenue cycle model, just to make sure we're all on the same page, I recognize not everybody has read that book. Not everybody listens to the podcast. Not everybody wants to hear from Taya all of the time. So just to make sure we're all on the same page, the revenue cycle model has 16 steps in it, but those steps really just break down into 4 primary sections, right? And that's the services that take place before the patient's been seen, the services that take place after the patient's been seen, us trying to get our money in, right? And then those essential value add steps that happen on the back end, right? That's where we're reporting, that's where we're getting quality program bonuses, things of that nature. In the first step, those pre-visit services, that's where we're getting information from the patient, right? That's critical information where we need to know demographics, insurance, coordination of benefits. The claims prep section, that's where we're getting information from the provider. What did you see when you talked to the patient? What did you document and what did you do in the room? The receipt of payment step, that's where we're getting information from the payer, okay? How well was this coded? What was your response to how we submitted information? How well did we document that? And that last step, step 4, is when we're evaluating our own data. In order to really successfully manage your revenue cycle model, you need to be able for each of these areas to identify, analyze, and optimize for people, process, and technology. These aren't just buzzwords. These are the steps that are going to help you truly improve your revenue cycle model. Now, a lot of times when we talk about revenue cycle models, people say, yes, we have a strong billing department. So we do want to make that clarification. Revenue cycle management is not billing. Billing is a component of revenue cycle management. Every step that you have in your facility touches your revenue cycle. Every activity taken by every employee impacts whether or not you will get paid, how quickly you will get paid, and how much you get paid, which is why you must have a strategic plan. Okay, so let's talk about this. Identify, analyze, and optimize for every touch point for people, process, and technology. What do we mean by that, right? This is our IAO, our identify, analyze, optimize. Everything that we have in our organization, if you've done a security risk assessment before, you're probably a little bit familiar with this process, right? Let's look at what's going on. Let's assess what's going on. Let's identify how we can improve upon what's happening. When we talk about doing that for touch points, we're going to be looking at every component, every point of entry, and that's touch points with the revenue cycle and with the patient. Okay, we want to evaluate what's happening. So let's take, for example, the check-in touch point. Let's identify what's going on there. Well, at check-in, we're not collecting copays. Let's assess that. Let's analyze that. Why is that happening? Right? And then we want to optimize. How can we ensure that we are collecting copays? How can we ensure we are collecting those past due balances, things of that nature? So for every touch point, you want to look at the components, points of entry, identify, analyze, optimize. It's the same with your staff, right? With your workforce and your stakeholders, those individuals who are carrying out the activities, right? Identify their skills, identify skill gaps, education gaps, right? Do they have the understanding and the knowledge that they ought to have to do that job? And if not, how can we support them? With your processes, so many organizations I go into, I ask, hey, do you have a process for this? I see a breakdown in this area. And the majority of the time, I'll say maybe 8 times out of 10, yes, a process exists, but no one is following that, right? And if you have that situation in your organization right now, you're not alone. Okay, there's so many organizations and facilities that have processes and spent the time to evaluate what they needed to have in place, but it was never put into place or it's no longer being followed. So we need to look at that. If our processes aren't being followed and they aren't being adhered to, typically it's not because employees just want to be bad and devious. It's typically because it doesn't work in their daily workflow. There's something wrong with that process. So we need to identify what that is and analyze how that occurred. How did this breakdown continue to happen? And how did this process continue to unravel? And how can we make it better going forward? Which is why we need to have all of the stakeholders in that conversation for processes. Again, we're going to dig into each of these, so don't worry. Technology, it's the same thing. And when we talk about technology, there's so much out there right now, right? I would love to see a show of hands in the chat. I don't know if I can see everybody's messages or just the hosts and panelists, but feel free to toss it in the chat. If you have more than 5 technologies, put more than 5. If you have more than 10, put more than 10. I want you guys to know that you're not alone, right? I want you to engage with each other and talk to each other and have those conversations that let you know you're not alone. This is very common in the industry to have care delivery platforms, clearinghouses, automating processes, that you have challenges with merchant processing systems, practice management systems. You have a hospital side and a private practice side, and your outpatient side is using a totally different system than the hospital system, right? You have all of these different things that build into your technology stack. And though you may have individuals who are experts and champions and SMEs in that particular technology, that doesn't mean it's all trickled down. And we've seen some devastating effects of that. So we're going to have those conversations when we talk about it, but please, please go in the chat, start conversing with each other. I promise you, you'll feel better about whatever your situation is. If you do want to look at what the total of these RCM touch points are so that you can start looking at how to identify, analyze, and optimize each of these, we have a slide in here for you, okay? These are the components. More than 5. Thank you, David. David, you get 10 fake points for being the first person that I saw respond in here. I don't know if I can see everyone's, by the way, Aaron, because it says I can only respond to host and panelists. I have a tendency to give out fake points, you guys. They mean nothing. They're worth nothing. You can spend them on nothing, but I'm going to give them out. Thank you, Angela. 5 fake points, more than 5. Yeah, it's challenging when you have more than 5, right? They all have their own passwords too. We have to reset constantly. So when you're looking at each of these sections, what we want you to do is make sure that you're looking at all of these from a people, process, technology, and touch point perspective, okay? For scheduling and pre-registration, what are the touch points for the patients? What people do we have working in these systems to obtain this information? How have we trained them? What technology have we given them? How have we trained them on that technology? What processes do we have in place to make sure that we're accounting for human error? And if there's a gap, that we account for that, right? So all of these steps you should be evaluating with the previous slide: touch points, people, process, technology, okay? We're not going to go through every single one of these today. Today, we're going to focus on the key critical touch points. And we're going to talk about why we selected the ones we selected. Today, excuse me, there's an echo, I think. Oh, and now it's gone. Good job, whoever fixed that. Thank you. All right. While we're building this today, I highly encourage you to start just building your strategic statement for your revenue cycle management plan. Now, often when we teach this in person, people start to feel a little awkward about writing this out, right? But one, we're not in person. Nobody's watching you right now. This is a great time to document this. And 2, putting it onto paper and solidifying it is going to help drive your direction, whether it feels silly or not. So please, please document. Let's see. Can you make sure you select everyone in the drop down? I would love to, honey. It's just not a chat, not an option for me. Let me know. And if I can't, I can't. That's okay. I can message to the hosts. Let's see here. I see 2 people that have responded in the chat, but they're both in host and panelists. So yeah, sorry about that. Thank you, David, for commenting. If you're commenting in the chat and you're in the everyone section and I have not seen your response, you get 5 fake points, okay? All right, so keep documenting, right? While we're talking, we're gonna address each of these components. If you are documenting your strategic statement, first and foremost, where you start off today as we are going through this presentation is not going to be the strategic statement that you have at the end of it. So you're going to see the immediate value of working on this as we go through the program today. So let's start with the strategic direction, okay? What is your long-term strategic RCM statement? And when we talk about your long-term statement, and again, this is when we get interactive, so make sure you're taking notes and you're answering these questions for yourself. How are you going to lead your team in the direction that we're putting into place for revenue cycle management? The way we do that is by setting the tone, okay? We want a clear, concise, achievable goal. And your RCM strategic statement, again, it should align with that business plan, but it should also align with who you are as an organization. You don't want to only align your statement to one specific area. And I want to be clear about that. And sorry, my dog's barking in the background, guys. I deeply apologize. You don't want to align to only one specific component. You want to make sure that your strategic statement aligns to really the genesis of where your business plan is going, right? You want to make sure that your business plan is relevant. And if it needs modification, you should modify that before you try to align your RCM statement to it. Your strategic statement is going to be the heart of this plan, okay? It's going to be unique to your organization, and you're going to use it to define your customers as well. So let's say, for example, the revenue cycle strategic statement that I have is, I want to improve our collections by 10% for non-indigent patients, right? Very just off the cuff statement here that we've got. While I document that first one, and hopefully you're all documenting your statement, look at this and really think, okay, what direction do you want your revenue cycle to go in the future? Does this align to that? Does it align to your business plan and who you are as an organization? Okay, so that's a good pre-program statement. If you don't have your pre-program statement, please document it. I want you to compare it to the final one at the end of the program. Your statement should answer 3 questions, okay? What's your revenue cycle management philosophy? How is your model going to be unique, either in the industry or to you or to what you've done before? And how does that benefit your customers, right? Because our patients are our customers, right? So we're going to talk a little bit more about that, but your statement should answer these 3 questions. What's your philosophy? How are you unique? And how are you benefiting your customers? Make sure that that aligns with your business plan, right? Which we've talked about a few times. Your business plan components have a lot in here. So you can actually use your business plan components as a checklist to analyze the operations that impact your strategic plan. So let's say you've gone through the RCM steps and maybe that's not the best direction for you, right? Everybody learns in different ways. So let's say you go through that and you say, okay, this is good, but I feel like it's not as comprehensive as I want. Use your business plan components, right? Go through. In terms of our location, have we evaluated the touch points to this location, the people, processes, and technology at this location? This is a second check for you. So you can use this also to assess what things are happening. The other good point about kind of cycling back to your business plan components is that typically after an organization has been started, right? Well, after startup, some of these things shift a little bit, right? Sometimes our mission statement changes a little bit. Our suppliers, our products, our services, our income projections, right? All of these things shift. This is something dynamic, right? It was a really static document when we got started, before we started up, or maybe the first couple of years of the startup. But if this is a long in place organization, perhaps it's time to go back and take a look at these business plan components anyway. If you are going to do that, all you need to do is take a look at each section, each area of focus. What is the current status of that, right? As compared to what it was before, what your current strategic goal is, the activities required to achieve that goal, and your benchmarks. The reason you want your benchmarks, you want to know when you can have a pizza party, right? We know that we've gotten 50% of the way when we see our denial rate drop to this percentage. And at that point, we're going to have a pizza party, right? It's important for you to track these benchmarks because you want to know that you're hitting those milestones along the way. So we put these 2 slides in here for you in case reevaluation of your business plan is something that you need to do just to make your life easier. When you are looking at the financial overview of your business plan, keep in mind that whatever presumptions that you put into place or assumptions that you're looking at when you're looking at that financial overview, you want to go in and validate those wherever possible, because those will also impact your revenue cycle management model. So these are in here just as supporting tools, but you want to make sure that you're doing those things. Now, the last thing I'm going to talk about before we really dive into the other components that impact your strategic plan and the way we're going to use technology to support it. The last thing I really want to remind everybody about is practice prep. Okay. When we do things like hire new staff, we outsource the service, we bring on a new vendor, we have a new contract. All of these components are sort of foundational columns to our building, if you will, right? All of these impact if we're going to get paid and how well we get paid. The credentialing of our new providers is going to impact how we're paid. If we've relocated, we have an acquisition, we have a merger, we need to look at our tax IDs, our NPIs. If we're outsourcing services, if we have vendor changes, this impacts our BAAs, this impacts our risk, this impacts our liabilities, our insurance, right? So if you do not have all of these things in order, You want to be very mindful of how you're looking at your revenue cycle, because the root cause of issues you're seeing may not be the genuine root cause. And I'm going to give you an example so you understand what I mean by that. We had an organization where the provider was being paid much, much lower than was contracted for the group. And it had to do with how the insurance participation had been added for that particular provider. Though everything was done correctly, it was never verified final setup with the payer. So the administrator files everything. They add a provider to the group contract. The provider gets added to the group contract. They have confirmation. They file that away. The payer has all that documentation. They file it away. Somewhere in the land of human error, somebody just typed something in wrong and put this in as a separate agreement or an offshoot of that group contract in the payer's database. So when the providers started seeing patients, they were not being paid under the correct amount. All of the paperwork was correct. The setup done by the administrator was correct. It was the look back that did not happen. And that look back didn't happen until we stepped in, which was a long, long time later. So the challenge there is that that's all lost revenue, right? There's only so far you can go back to collect that. So you have to look at these things. You always have to make sure that they've been set up correctly. And you always have to do that look back to confirm that things are happening correctly, right? Because those are going to impact your revenue. They spent a lot of time trying to determine, was this provider not documenting to the highest level that he could be documenting to? Did they need additional coding audits? Did he need additional training in the system? Was there something wrong with the way the coders were submitting the documentation? A lot of time was wasted here, guys. So make sure that you have your house in order whenever you're looking at problems in your revenue cycle. All right. Value-based programs. Legislatively, things are going to happen all the time that collide with what we're doing in our practice, and they're going to impact our revenue, right? If you were around for meaningful use, for PQRS, MACRA, MIPS, you know this already, right? You know that things happen that can significantly impact our revenue. And so you want to keep these things in mind when you're building your revenue cycle strategic plan. Are there external factors that are going to impact your planning? You don't want your plan to be so rigid that it doesn't account for these. Now, we have a session later today on what to expect at the expiration of the public health emergency. That's another example of how an external factor can impact your revenue cycle. So you want to make sure that you're including these factors in your revenue cycle statement. Okay. So for example, when we look at scores over time and the changes over time, cost as a factor was 20% for MIPS in 2021. It was 30% in 2022 and will be 0% for APMs in 2022 because they received those risk-based distributions. But when you look at these changes, you see cost becoming an increasing factor. We anticipate that that's going to continue over the next few years, because we want to reduce cost, right? We know that our nation has one of the highest costs of any other nation. This is an example of something that's happening from a regulatory perspective that is going to impact your RCM statement, right? You can't just throw additional resources. We really have to be mindful of what those are costing us. In addition to, not just in bringing technologies on board and bringing staff members on board, right? But cost of readmissions, the total cost of that patient's care and that care continuum, right? No Surprises Act, all of these things are going to impact our revenue cycle model. So all of these things need to be in our plan. We need to know how we are going to deal with each of these in ways that leave us financially solvent. If you are familiar with Maryland's total cost of care program, Maryland is working on and has been, they're in this long-term program right now. And I think it was a 10-year term. Yeah, it says right here, 10-year term based on performance. It started in 2019. This was based off of a pilot that they did the previous 5 years. And this model, this all-payer model, makes everybody responsible together for the cost of care. It's a great program. It's a great model that they're working on. It is unique to Maryland. The reason that we're showing you this is so that you can see that these regulatory changes that impact revenue cycle don't just come from the federal level, they also come from the state level. So when we're looking at regulatory changes that can impact our revenue cycle model, we need to be looking at all external causes. Okay, we also included this slide for you, because now that we've started to dig into each of these for a little bit deeper, we want you to know what you should really make sure to touch on as you're going through each of these steps and evaluating, right? Identify, analyze, optimize for touch points, people, process, technology. At some point, this is just going to become a mantra in your head and you're going to do it. But we wanted to put on here some key areas that will drive revenue cycle change in a positive direction if you evaluate and tackle these, because we know that telling you to tackle everything is a lot. Okay, so if you can only focus on one thing in each of these areas, we've given you some of the key components that will really drive revenue cycle improvement. In terms of other external things that are significantly causing disruption to the revenue cycle, and this, forgive me, we've been presenting this presentation for a very long time. Right now, the public health emergency is set to expire in October. We expect on the Hill, I'll say, because I'm on the Government Affairs Council for MGMA, we do expect them to renew it through the end of the year. That doesn't mean that they will. We'll talk more about that in the afternoon session today, but make sure that you're looking at all of these temporary public health emergency waivers, okay? HIPAA penalties for good faith efforts, state licensure expansions, the virtual incident to originating site flexibilities, the waiver of beneficiary cost sharing. You're going to want to make sure to evaluate all these. When you talk about your revenue cycle strategic plan for 2023, you will not be able to include all of these things. Some of these things are going to go away when the public health emergency expires. If that happens in 2023 and telehealth, for example, is a large component of your revenue cycle model, you want to make sure that you still have the state licensure components that you need, that you still have the oversight that you need for incident to requirements, and that you're still meeting originating site requirements, right? Because the proposed finalizations for these are only for mental health. So you do need to look at all of these things that can impact what's going to happen to your organization. We have some high-level review of the 2022 final rule highlights. I anticipate that at this point in the game, it's September, that you guys know what these are. If you don't, that slide is in there for review. Now, just like we did with the RCM steps, we know that telling you to look at everything is a lot. So here are some key areas you can start with. Take a look at the changes that were made to Stark Law, the information blocking rule, and the anti-kickback statute, okay? There's some other areas in here that we highly suggest looking at, but these three changes, all three of these can impact your revenue cycle, so take a look at those. Now let's get into operationalizing on this, right? We talked about core competencies. We talked about getting started. We talked about really defining what do we want to do? How are we going to do that? How are our external factors really impacting what we're doing? Okay. The way we operationalize first and foremost is with workforce. Okay. Now, we only have a limited amount of time today. So we're going to focus on two areas of our core competencies. First and foremost, workforce optimization. Is our workforce being optimized? Oh, that's a challenging question, right? I mean, when we look at the numbers and the rates of reimbursement, employee costs continue to increase, okay? If anybody looked at this and you were like just shocked, have that conversation with each other, talk about this. I saw an ad a couple of months ago where medical assistants were able to get a $5,000 sign-on bonus. I remember being a medical assistant many, many moons ago. And the opportunity to work at a facility for minimum wage was really the benefit for me, right? I can't imagine a world in which I would have gotten a sign-on bonus for being an MA. So we know that we're working in a unique time period, right? We've gotten so many questions about this. We know there's the great resignation happening. We know people are jumping ship and going all over the place. How do we solve for that? Most of it comes down to culture, right? The employees that can work from home, let them work from home. You know, can your billing staff work from home? Can you support that? Does that mean that you have reduced overhead? Absolutely, right? I get a lot of questions on, well, how can I track people? Should I put cameras on them? People tend to perform better when they have a little bit of trust. Yes, you always have to truck on that, right? Trust, but verify. But we also get a lot of questions in terms of what does that mean for work from home employees? Can you pay them less? Technically, yes, if you're able to evidence legitimate reasons, right? Like I have an employee in New York and I have an employee in Omaha. The employee in Omaha, the general rate is going to be lower than it is in New York. So for that reason, we want to pay that employee less. Yes, you could do that. Generally, we don't recommend it. Staff tend to find out, it leads to staff attrition. You can always have that policy of we do not discuss our salaries. People are going to do it anyway. It just is what it is, and it happens. There's an article in there on the pros and cons of decreasing wages for remote employees. We just don't recommend it. Do you have to pay for employees' internet and office supplies? Right now, there's no federal mandate. So what you want to do is check on your state laws, check with your state regulations to see if there are things that you need to pay for if your employees work from home. And if you're looking for additional information on writing policies or communicating benefit changes, things like that to staff who change to work from home models, you're going to want the guidance of HR experts. So look at your SHRM experts, talk to your legal counsel, look at the resources that your payroll company provides. And also your biohaz companies also often provide information. So look at all that information that you have before you make any changes to position requirements or to compensation. Just make sure to put in that time to do that research and due diligence. All right, now with that out of the way, when we are evaluating staff and we talk about looking at workforce, first things first, we need to know what they're actually doing, okay? Their job description is one thing, but actually sitting at their desk and doing their job is completely different, right? So we want to do desk audits. The word audit can sound a little scary, so feel free to title it whatever you want. But what we want is for each employee on their own to document what they believe to be their duties and responsibilities and what they do all day, right? And this is not a competitive thing. This is not meant to get anybody in trouble. This is meant for them to show management. What is it that you're doing? Where are the challenges? Where are the difficulties? What is the most frustrating thing in your day? What can I, as your employer, do to make your job easier? That approach is going to get you more honest answers than any other approach. And what you're looking for as a manager isn't, hey, now I told so-and-so to do this and somebody else is doing this. I need to go hand slap. What you're looking for here is, where do we have duplication of effort? Where do we have a lack of training that's leading to frustration? Where do we have areas where potentially technology could be supporting what people are doing? What can we automate? Do we have employees that are being overutilized or over-relied upon? Do we have employees that are being underutilized? Do we have employees who believe their supervisor is somebody it isn't? And how does everything they documented that they are doing on a day-to-day basis actually compare to their job description and what they're being reimbursed for? Many times we believe that staff are being appropriately reimbursed based on their job description, but their job description does not align to what they're actually doing on a day-to-day basis, right? So take a look at this. Find a way to have these conversations with staff and let them know, and really make sure that you abide by this, that no one is penalized in any way, shape, or form based on what they put in their desk audit, okay? This is not for a stick moment. This is an evaluation moment. This is to get documentation to better drive your directions for revenue cycle. Once you have this information, perform a staffing role and ratio analysis, okay? All of this drives back to how well you're going to be able to tackle your revenue cycle. So let's say we're looking at this for these two providers, right? We've got Dr. I, Dr. That, and these are all of the employees that we've evaluated. They tell us, or Either they tell us or we're assuming on our own what activities they're doing here, okay? Who's doing checkout, check-in, answering phones, doing eligibility, working the inbox for EMR and the patient portal, or performing charge entry, or any other uncategorized duties, right? We want to make sure we're evaluating that so we can see what employees are being underutilized, what employees are being overutilized potentially, or what employees are doing something that they shouldn't be doing, right? It's not on their list to do. For example, here we have a part-time employee whose job is to do check-in the phones, manage the inbox, do charge entry, and then has a bunch of other uncategorized duties. Well, why is this individual only working part-time? Or why is this individual assigned all of these tasks, right? Are there other things that we can be assigning to someone? For example, we have these 4 individuals doing checkout. Now, perhaps they're not all doing checkout all the time, but why are they not all capable or trained to do check-in? Why are these 2 things totally separate? We want to make sure that individuals are also cross-trained. So are you right staffed to meet your goals? And does your workforce have the necessary skills, resources, and opportunities that they need to do their job? Now, this doesn't mean you have to physically sit down with them and have these conversations on a day-to-day basis. There are a ton of professional development tools out there, right? There are, the American College of Healthcare Executives, Practice Management Institute, MGMA, HIMSS, AHIMA, HFMA, AAPC. There are a ton of organizations. There's a ton of free information out there. So you want to make sure that you are giving staff the resources that they need, because those resources exist. And once you give them the resources they need to do their job, they are going to perform it better. I cannot tell you how many times I've gone into an organization and talked to the front desk and asked them, do you know how we get paid? And they cannot answer the question, right? They should be trained in the entire revenue cycle model. They should understand that what they enter impacts whether or not we get paid. And if they enter it wrong, all the steps that the billing department has to go through to correct it. There's a reason the billing department and the front desk don't always get along, right? They don't understand what the other one is dealing with. So we want to make sure that we have those conversations. There are a ton of workforce management tools that are available also. If you have a workforce management tool, if you have a very large facility, if you're working with more than, let's say, 50 employees, you're going to want a way to optimize your view. So make sure you're optimizing your dashboards. Look at your workforce by department assignment. Evaluate cross coverage. Have a way, an easy method of tracking OT, of tracking PTO, of tracking provider assignments and patient loads. If you're still doing all of this manually in spreadsheets with pivot charts, a lot of this and workforce management capability is probably available to you in a system that you already have, especially for those who said more than 5. Look at your payroll vendors for workforce management tools. Some practice management systems are even expanding to have this capability. So take a look at what is available to you. And we're going to take a moment on this next slide. I really want you guys to think, when you think about the technology and the software that you have in your organization, pick one right now. Let's say your practice management system. Do you know all of the capabilities of that system? Really think about that. Do you know all of the capabilities that are available to you today in the system that you have today? If you don't for each of your technologies, you want to dig in, right? If that means you have something already implemented that can be supporting you to faster reimbursement, we need to make sure we're taking advantage of that ASAP, right? There are going to be errors in how we use technology because we're all human, right? There's tons of ways to minimize the errors that we have. There's a great articles out there from the National Institute of Health and from IHI. I would highly recommend going out to both of those. The Institute for Healthcare Improvement and the National Institute of Health are both looking at ways to help reduce the impact of the human element. And that doesn't mean we want machines to do everything. What that means is we want the machines to recognize that there's human error and help us correct the human error in data entry. Okay, so we want our technology to alert our providers to potential duplicate patients. We want to do that in ways that does not create alert fatigue. So we want to improve our data displays. We want to train our users on how they should be evaluating things and cross-validating, and again, in ways that don't create alert fatigue. So how can we develop tools to compare key demographic data in the background and calculate the estimate of that? We actually, today in the industry, there are tools that will do that for you, that will evaluate, hey, you have duplicate records in here. Do you want to merge these records? The demographic information was 99% the same, right? And then instead of evaluating and you going out and finding the information, you're just confirming it and saying, yes, merge. There's a ton of capability out there, but in order to make sure that we're using it appropriately, we need to make sure we do that user training, right? We need to make sure we understand our technologies. I'm going to give you an example, and this is a case that I personally worked on. In 2019, I was working with an ACO in the Midwest. They had a ridiculously high number of rejected claims. Okay, so it was slowing their payments down, a lot of additional work, contacting patients, redoing coordination of benefits. They put their staff, and I say they, we led this team to go back through training of the practice management system. We were really far into this retraining. Now, mind you, we brought, they were using Allscripts at the time. We brought Allscripts on site to do retraining. They retrained the billing staff first, then they start retraining the front desk staff. The front desk staff, this is when we found the error. The front desk staff thought that a green flag on their scheduling screen indicated the patient's eligibility had already been verified. The billing department thought the same thing. And it turned out that that flag is not an indicator of a completed eligibility verification. It was an indication that information was in the system and eligibility could be run. If eligibility had been run, that changed from a flag to a check mark. So we educated the staff to then begin verifying all patient eligibility at check-in, regardless of the flag type, regardless of the color, unless it was a check mark, they needed to verify patient eligibility. The accuracy of their demographic entry increased by double-digit percentage, and the number of rejected claims decreased by 47%. When we know more and we know how to use our systems better, we do better. This is a real world example of a very, very, I will say, technologically savvy, cutting edge ACO. This is an example of just that human element. Someone misunderstood what that meant, pass it along to someone else. It kept getting trained that way. It was actually a part of a process that they had documented. Look for the green flag. Make sure we know how we're using our technology, okay? When we talk about data optimization and structured data and looking at this information in better ways, look at SAFER. So the safety assurance factors for EHR resilience, or SAFER. Right now, these are not being scored. These are in the promoting interoperability category for MIPS and for APMs, but take a look at that, because what it's doing is giving you great information and insight on how to start structuring your technology and your use of technology in ways that make sense for organizations to really excel. If you are doing things like remote physiological monitoring, treatment, things like that, you really want to make sure that you have great data plans in place. So if you're doing anything like that, we have a quick guide in here for you on those requirements. Okay, are your codes correct? Did you do a financial analysis in terms of reimbursement? Have patients been equipped with the technology? This is a popular service, right? Because providers are expanding their virtual care delivery and the need to monitor patients virtually. This can only be reported once a month, but this is something that we're seeing being billed more and more frequently. This is an example of a technology that is external to your practice management system or EHR, and its opportunity to either help increase your revenue or its opportunity to not be reimbursed. So everything that you are doing from a technology and reimbursement perspective, again, identify what it is you want to do, analyze what is needed to really achieve good results, and then optimize the use of that and what you're using it for. always do a look back, make sure those reimbursements are coming through the way that they were intended to. So when we talk about analysis, because I keep saying analysis, right? You guys might be getting tired of analysis. What methods are we talking about? When I say analysis, analyze this. What are we doing to perform that analysis and do those internal assessments, right? First and foremost, a coding assessment tool. I think you don't always have to do a full gigantic chart audit. You can on a regular basis be doing coding assessment tools. And this is an example of a real assessment that was de-identified to be used as a coding audit sample. What you want to do is select the best practice benchmark for a percentage of your levels to be accurate and determine your method that you're going to address over and under coded claims, right? When we have over coded claims, we're going to be outside of the bell curve for payers and we're going to get audited. There's a good chance that some of that is going to be retracted. So we want to look at why we have claims that we are deeming overcoded. Does the documentation actually match up? We also want to look at undercoding, okay? There are times when providers don't want to get in trouble, so they will bill level 2s and level 3s when the service is really a level 5. This comes down to education and comfort level. So we want to make sure that we are educating on how that coding should happen. Now, when we're using encoding tools, sometimes those can be misleading, right? Because again, that's the machine element, not the human element. So we want to make sure that even if we're using an encoding tool, we're evaluating that. We're reviewing the problem list. We're updating diagnoses. I went into a coding, into a chart the other day to look at the HCC for a patient, and it said they had suspected diabetes. They had diabetes type 2, without complication, and they had diabetes type 2 with complications. The patient should not have all 3 of those diagnoses at the same time, right? Our problem lists need to be active and current. So we do these coding assessments to evaluate, is the coding level correct? Is the E&M level in the correct category? Right? When we look at the total, how many were correct overall? How many were incorrect overall? How many needed an additional code that wasn't present? We also want to look at these things by provider, okay? So when we look at our providers, what's the accuracy level by provider? And for those with a really low accuracy level, what's going on there? You know, is it that things are being overcoded significantly? We have 85 that were overcoded by 1 level, 17 that were overcoded by 2 levels. These are things that we need to be talking to our staff about, because fraud, waste, and abuse is a real thing. And if we are operating in best practice, we don't want to get dinged for fraud, waste, and abuse, right, in an audit. So we want to make sure we're doing everything we can. Now, the coding assessments, this stuff is helpful because it takes us in the right direction, right? But the really critical details, those come in the auditor's comments, okay? So make sure you're using those auditor comments to take corrective action, to modify templates that you have in place, right? So for example, this one, the patient's medical history was not reviewed, so the visit is disqualified for being an annual wellness visit. So when this is billed as an annual wellness visit, it's going to be, if it's paid without a review of documentation, then it may be subsequently taken back upon audit. Or if it's sent in with documentation, it may not be paid as an AWV, and you may be chasing that information later to figure out why that happened. But if you're regularly doing coding assessments, you would have seen this information in here from your auditor's comments, right? That changes how you want to talk to your providers, right? Auditor's comments, telehealth visit, new patient to provider, established with the practice though. So you want to look at these, right? And retrain on the documentation guidelines. What is a new patient? What is an established patient? The first doctor I ever worked for said, I learned how to be a physician. I did not learn how to run a business. We have to help the providers. This is not stuff that they just learn in medical school. So take the assessment tools herein. Here's another one that we've provided for you. This assessment tool is for a hybrid telehealth model. These are the bodies of knowledge, the areas of domain from MGMA's body of knowledge, if you've seen those books. Look for each of these areas, create a sustainability measure and create a KPI to that. If you build these into your strategic plan for your revenue cycle model, right? 30% increase of virtual visits. This is a very clear direction that we want to go in. This is much more clear than I want to increase my revenue, right? Or I want to decrease my denials. We want to have increased use of 99214. This means we need greater education. We don't just tell staff, hey, start coding this, right? We want to make sure that they understand E&M guidelines so that they are using this code when it is appropriate and not using it when it isn't. So go through each of these and identify, the measures that you want to meet based on your organizational needs, establish those achievable benchmarks to gauge your success or improvement needs, and then start building these into your strategic plan so that you can start tackling them one at a time. Okay, so I've given you guys a lot of information. The next real, just less than half of this program, we're going to start moving a little bit quicker because this is the actionable stuff that you should be doing right now, right? Build it into your RCM, but we want you to start doing these things right now. First and foremost is your fee schedule analysis. Your fee schedule analysis is so much easier to do if you're using the technology available to you. So we talked about your practice management system. It's been a long time since I was in a practice management system that did not allow for the entry of allowable amounts. Go through by contract and enter your allowable amounts. This makes your fee schedule analysis much, much easier. When you're performing that, you want to use Medicare as a benchmark. Then compare the charges to your allowables and to your contractual adjustments. Compare the payers to each other. Do they match your fee schedule? Are the charge amounts more than your allowed amount, which is what we want? If the charge amount is really close to your allowable amount, maybe we need to adjust that, right? Your fee schedule analysis is giving you a bunch of information here. So for example, let's look at this spirometry, right? With the technical component modifier. We're charging $50. Medicare's paying $30. We did 475 of those. But payer number one, who is our primary payer, they have nothing listed. So do we need to have this conversation with a payer? What are we being reimbursed for this? Is it comparable to Medicare? Is it comparable to our charge amount? Or are we not being reimbursed at all because it's not on our list and that's what our contract says, right? So we want to take our fee schedule analysis and look at it a few different ways. You want to compare the payers to each other. Then you want to look at total volume, right? 99205s, we had 1,500 level 5s and only 300 level 4s. That says to us that something's odd, unless our specialty indicates that, yeah, our new patient visits are generally going to be a level 5 visit. So we want to look at what this data is telling us. What does this data represent we should do with our revenue cycle, with our education of our staff, with our technology checks, with our payer contract negotiations. And when we dig into payer fee schedule negotiations, it's going to feed that information, right? This is going to let us know what is one payer paying versus the other payer. What are we now requesting from the third payer? If you have all of your allowable amounts entered by payer into your practice management system, you can then export that information, de-identify the payer information, and come up with average rates of payments from your 3 highest payers. And you can use that data in your contract negotiations with other payers to indicate to them, hey, you guys are paying us $20, but you'll see these other 3 payers are all paying us more than $30, right? You can send that information as supporting documentation. So get those allowable amounts in your practice management system so that you can support yourself. This is also going to help you with your paid claims analyses and your net collect ratio. Analyzing the data in various formats is what's going to help you identify trends, okay? So when we're giving you all of these different methods, the coding analysis, the fee schedule analysis, a negotiation analysis, the paid claim analysis, all these are driving you to look at your information in different ways so that you can capture an idea of where your real challenge is. So for example, here in this one, BCBS PPO, 41% of the total volume, but it's only 8% of practice revenue. Why is it only 8% of practice revenue? In contrast, when we look at United Healthcare, for example, United Healthcare, is 5% of total volume and 15% of practice revenue. So we want to look at why that is. Why does United Healthcare have the 6th highest claim count, but it's the top revenue source, right? And perhaps that means we're going back and we're looking at our fee schedule analysis, or we're looking at our payer fee schedule negotiation. Maybe we really need to renegotiate with the Blues, right? This is giving us additional information on what's going on with our organization and how we're being paid. And these are fundamental areas that we need to tackle for revenue cycle management. You can do the same thing with value-based programs. If you're participating in more than one value-based program, then you really want to evaluate what measures apply to more than one. Okay, so if you are working in more than one, let's say you're participating in all of these that we have listed here. Okay, so we've got MIPS, PCMH, HEDIS, we have EPSDT and APMs. And it's very likely that if you have a large facility, you have multiple programs. Well, what measures meet multiple programs? Because those are the ones that you're really going to want to focus on, right? So preventive care and screenings for BMI and follow-up plan. This is going to be one of your top measures that you're talking to staff about because it hits everything you're doing. So do labs, so do depression screenings, right? We want to make sure that those things that are impacting all of the programs that we're in, that we're really looking at those and driving adherence and driving compliance. We don't want to spend a ton of time really making sure and hammering down on the radiology dose exposure because that's only for MIPS. We really want to focus higher on the things that are impacting the entire organization and all of our programs. So when you're looking at this data, again, looking at it in multiple ways is going to help you drive your strategy and make those bigger impacts faster. So what methods are we using to determine success and failure when we do those evaluations? That's when it comes down to the KPIs, right? Your key performance indicators. KPIs are just a great way to measure your achievement and adherence to your business process goals. If you have a good KPI, it is providing objective evidence of progress towards achieving your desired results, okay? You want to measure what you intend to measure, and you want to offer a comparison that gauges the degree of performance over time, whether you're tracking efficiency, effectiveness, quality, timeliness, whatever it is, right? You want to make sure that you're measuring what's intended to be measured over time, right? So when you're doing that metric selection, you just really need to define what is it that we want to measure, okay? Then analyze the business process associated with that to determine how could we measure that? How can we measure it over time and determine, okay, for what we want to look at, what does it look like today? And then what would we like for it to look like in the future, right? This is how we come together with our KPI. And once we have that, we can determine how we want to get there. When you're looking at KPI curation, right, and putting those KPIs together, the indicator portion of KPI means the information you have, right? Indicator means that what you have isn't final. It's not full, but it helps inform that decision making, right? It's an indicator of where you're at. When you're performing these, you want to look both vertically and horizontally. So you need to ask yourself some very specific questions. What questions do you get asked the most by executive leadership or by your supervisors or by your staff, right? Because those are KPIs you're going to want to create. What matters most to your audience, right? Or your staff, or perhaps even patients or marketing? What is the main topic of discussion often when you have your meetings or your huddles? Perhaps you want a KPI around that. If you don't have KPIs developed yet, these questions are going to help you kind of navigate towards some that you can create. The next set that you really want to ask yourself is about the data, okay? Is the data digestible? Does it make sense? What decisions are you going to make? It's great to have a KPI, but if it means nothing to you and no decisions are going to be made off of it, then it's not useful to you. And you also want to keep in mind that doctors are scientists. but they do like easily digestible information. So use colored charts, use pictures if you need to, link to those, link to other articles, those reference articles if you need to, right? We want to make sure that we're getting this information in ways that is going to be digestible. When we talk about the use of KPIs for decision-making purposes, let's look at unique patient visits, for example, as a KPI. If we have a KPI for that, right, and we say this is our current number of unique patient visits, this is the number that we'd like to see next year, that is going to help drive for you your staffing needs, the use of exam rooms, appointment optimization, the wait times for patients and what's acceptable in terms of wait times. And you can do this for every KPI that you have. You can use that to drive your decision-making process. Use it for diagnoses utilization, use it for referring providers and increasing referrals, use it for adjustments and evaluating adjustments so that you can evaluate your processes in coding and documentation and in your contracts. KPIs can be used for decision-making in tons of different ways. And so it's really important for that reason that you're appropriately benchmarking your KPIs, right? So benchmarking is that process of comparing and measuring the areas of your organization with industry best practices and standards. So you're on an MGMA call today. MGMA has one of the best data sources. If you submit your own data to MGMA for all of their cost surveys, financial surveys, productivity surveys, you get access to the national data for free. There's not many other organizations that offer that. You can also go out to data.cms.gov and get a ton of information. You should get data from multiple sources. Same reason you should check your own data multiple ways. It's going to give you different insights. And where you go to get data should also be determined by what type of data that you need. If you need data specific to your specialty, you should go to your specialty association because they are going to have more information specific to you. If you want to look at what other providers in your geographic area are doing, you may want to go specifically to MGMA. If you want to see what's happening with Medicare patients across the board, then perhaps you're going to CMS. And combining that information is going to give you really comprehensive, higher quality understanding of what you're looking at, right? Use KPIs. Look at your payer mix, your payer income, your patient age and gender. All of this is telling you what resources you need to have, what resources your community needs for you to provide, how you should be improving your revenue capture and things of that nature. And what do you do though if you cannot track these KPIs in your system? Because we're talking about all these, right? But perhaps that's a challenge for you. And right now you're thinking, well, this is fantastic, but this is a lot of documentation, and how are we supposed to track this? I will give you a few things. One, your practice management system, chances are a lot of this can be captured in there. So again, dig into that technology, understand the maximum capabilities. The next, your clearinghouse. Your clearinghouse will have a lot of this information and KPIs already built into report structures and dashboards that you can use and access. So make sure you fully understand that technology. And next, if you absolutely have to, we can build this out in Excel, right? We can take a look at our own benchmarks. When we're looking at our own benchmarks and we talk about percentile, the percentile is where a score stands relative to other scores. 95th means you scored higher than 95% of other scores. My daughter, her head is in the 99th percentile, which means it's bigger than 99% of the other children. When you are calculating percentiles, we gave you the formula right here and what that means, okay? The benchmark should be your standard to gauge. You want to measure one thing in comparison to something else. Your benchmark item should be reputable. It should be stable, okay? Our benchmark should not have a ton of variance. This should be coming from the data that we pulled from MGMA, from CMS, from our other associations, right? And For example, when we talked about our fee schedule analysis, I said we're going to use Medicare as a benchmark because those fees are set annually and they're not varying on a day-to-day basis, right? We want to have benchmarks that have a limited amount of variance in them. And then we really want to make sure that we're leveraging that benchmark data sufficiently. Okay, so define those metrics, identify the data that's available to you, and look at your time frame. Okay, so for example, CMS, when they were going through and looking at performance data, they came out and said, we can't look at the year 2020. That data for us, it's just not reflective of what's going on in the industry because that year was too crazy. It was too impacted. So in terms of time frame, we are not going to look at that data. We're either going to look at 2019 or we're going to look at 2021. Your time frame matters. And sometimes the difficulty with your time frame or something that may have significantly impacted is unique to you, right? So if you're trying to look at expenses and you want a benchmark for what the expenses are for Q3 every year, but 1 year in September, you relocated and had a ton of additional expense. That's not a good benchmark year for you, right? So make sure you're careful in the selection of your time frame. Then create your internal goals and prepare to benchmark yourself against others. This is going to drive the approach for your strategic plan, right? Your approach is going to in part be defined by what do you want to get to and where are you today and how do we get to that? So how do we communicate our approach, right? Because once you've got all the data, once you've assessed all the data, you have your KPIs, you have your benchmarks, and you say, okay, we are here, but we need to get here. And this is how we would like to potentially get there. That has to be communicated, right, with all of the stakeholders. So as part of your strategic statement, one of the questions I asked you to answer in the beginning is, who is your customer? Okay, your customer is your stakeholders, which does not just mean patients. We have internal stakeholders and external stakeholders. So we have patients, physicians, ancillary staff, hospital systems, referral sources, insurance payers, regulatory entities. We have all of these stakeholders and all of them have a different expectation for us and they have a different primary need from us. And we need to keep that in mind when we're talking about our activities. Now, hopefully you guys are still awake. I'm dragging you through a lot of strategy here, but I promise you, if you hold on to these slides and you go through them with intent and documenting your own strategic steps, it's going to make a significant difference for you. So we're going to spend our last just under 20 minutes or so talking about the activities and application. All right, this sheet, this is called the RPO, the Reactive Preventive Optimize. I want you to use this wherever you see fit, okay? When we talk about React, Prevent, Optimize, what we're talking about is looking at what is happening in our organization and evaluating the opportunities therein. If we look at what's happening right now in our organization, what does the data tell us is causing issues? Then preventively, what can we prevent from happening? Where do we have opportunities to negate these issues from occurring in the future? And after we have sort of stabilized things in this phase and prevented it from happening again, how can we optimize on that? How can we get to where we really want to be? And I highly recommend, if you cannot do every area right away, let's focus on 4 activities and 3 steps. Okay, so we're going to react, prevent, and optimize across denials, AR, contracts, and reporting. So if you're wondering why these areas, because these are your opportunities to collect upon revenue that was earned. These are your opportunities to get in your money. This is your opportunity to look at how hard we can fight for our money. And this is our opportunity to understand how well we're doing currently, okay? Remember that revenue cycle management is not in a billing department silo. This is practice-wide. When we talk about denial prevention, there are a range of reasons that claims get denied, right? Some are prior auth denials, some are due to errors, some are due to coverage issues, etc. There's all kinds of reasons, but a failure to follow the steps required is what we see most often. So let's take a look at how we would apply the RPO to denial prevention, okay? In our reaction phase, perhaps we're looking at what claims have been denied in the last year. What were our top 10 denial reasons? What services were most frequently denied? And what can we infer from this data? What is it telling us about our current process or potential process breakdowns? Of the codes that were denied, what were denied due to things that we could have prevented? Where do we have the opportunity to prevent those denials in the future? And because we're establishing KPIs the whole time, what would we prefer to see our denial rates at? What are some of the methods by which we could get there? And how can we use our technology to minimize the duplicate workflow that is required to make sure we're optimizing things, right? We don't want to have to do multiple submissions anymore. So we're using this RPO for denial prevention to drive revenue integrity. Look at all of these potential questions you can ask yourself. And I will tell you, the biggest challenges for denials are failing to appeal or resubmit, rushing through the appeals, or not tracking allowable amounts versus reimbursed amounts. If you really want to drive yourself crazy, according to the OIG, MAOs overturn 75% of denials upon appeal, but 65% of denied claims are never resubmitted. We have to make sure we are looking at these claims and that we're getting things reimbursed. We don't work for free. We don't submit claims with the intention of never being paid, right? So how do we identify problem areas? First and foremost, group denial codes. This is going to point you toward workflow process issues. This is going to point you toward department issues. Then take a look at the percentage of claims that were paid at the first submission. That's showing you your billing and data accuracy rate, right? This is a number that you want to see increase over time. It's never going to be at 100, but we want to see it continue to increase. Your net collect ratio, that's telling you of what you were eligible to receive of your allowable amount. How much did you receive? Okay, so of what you could have gotten, how much did you get? For anybody who's got providers that constantly look at the amounts adjusted and think that, you know, that's the amount that needs to be decreased, because maybe they don't understand the charge process or what adjustments represent, this is a great ratio to look at instead, because this is looking at the allowable versus what was collected. Look at your days in AR, look at your time of service collections, and always confirm with the data. There's a great chance you have a sixth sense for what's going on in your organization, but in order to make sure you're actually going after the root cause, you have to confirm with data. The best way to do that is to try to disprove what you believe to be the cause. Other indicators of data entry or verification problems. When I tell you to group by denial codes, this is what I'm talking about. Let's say you group these codes, 22, 26, 27, right? All of these are indications that we have some challenges with eligibility and benefit verification, right? Care may be covered by another payer, expenses incurred prior to coverage or after coverage. Patient cannot be identified as our insured. All of this, when I take you all the way back to that pre-visit services, this is where we're getting information from the patient. This is patient check-in. All of this should have been captured there, right? This is why the billing department is mad at them. They don't know the issue that this is causing. So when we group these denial codes, we create this way to evaluate this data, to track a KPI, to show the front desk, hey, this is how well you're performing right now. We want to get them this information so that they have a way to look at their own success and accuracy. Improving data entry is always going to be a challenge, okay? The best ways to improve data entry is to really educate your front desk staff, because that's where 92% of your denials are coming from. And I did not just make that number up, that there's a link in the slides if you want to look at that. 92% of denials come from data entry, and that's just a staggering number. The way to decrease that, one, wherever possible, you need to automate. Use the technology available to support you. I was in a facility where if a patient called in on their cell phone, it launched the patient's record on the screen of the staff member that picked up the phone. Now, most of us don't have facilities big enough to be able to implement that level of technology, but there's still a ton we can do, right? We also want to build in somewhat of a habit for people. We want them to verify every patient every single time. Just asking the question, does your phone still end in 1234? Are you still on 7 Main Street? Will verify that we can get in touch with the patient, right? Those are 2 quick questions. When your staff gets overwhelmed, they're going to default to their routine. So we want to make sure their routines are solid. And we want to keep in mind that this is a carrot moment. This is not a stick moment. The front desk wants to perform well. They're just overwhelmed. So the more we can support them and reward good accuracy, the more improvement we're going to see. We also want to make sure we're evaluating the cost, worth, and value of our denials. So we talked about putting the allowable amounts into our practice management system. This is important because all denials are not created equally, right? Chances are that if you're on this call, your team either works their denials based on the date of service or based on the claim amount, right? So they're either working based on the total charges or the date of service. What we want to look at is what is the value of that claim? So first, you'll want to do some digging into your data to identify what it cost you to work claims. If you can look at what it costs to work them at varied stages, do that, right? First appeal, we know it's going to take us a couple of hours. Second appeal takes this much time, right? That'll inform for you when a claim should no longer be chased, because you'll know this is more effort than it is reimbursement. Then you want to identify what your average loaded cost is to work a denial. Across the board, if we have touched a denial and worked it in any form or fashion, this is our average cost. That's going to inform whether or not a claim is worth your effort or should be outsourced. For example, if it cost you $45 on average to work a denial, then you should not have your staff work any claims that are $45 or less, right? You may want to outsource those to a lower cost collection method. You need your worth. That's the allowable amounts that you put into your system. So we've got examples here. Service A, the charge amount is $350, but the allowable amount is $100. Where the charge amount for service B is $200 and the allowable is $125. This one actually is a higher value to the organization. Once you know the cost and the worth and the value, you can develop your internal strategies. You can say, okay, we're going to work our high value denials first. We're going to watch timely appeal for anything that's sort of in a mid-range value. And we're going to outsource those low value denials or move those move them to lower cost workflows wherever possible. When we talk about applying strategy to denial management, this is what we're talking about, right? This is a very clean strategy where we are working the most valuable things and making sure we're spending our time in the places where it makes the most sense. Now, there are a couple of case studies in here for you. There's also some best practice steps in here for you. I'm not going to take you through every single one of these because I think that you're starting to get a good idea, right, of what we mean when we say obtain your data, assess your data, look at this information, evaluate your denials, right? And we want to do the same thing as applies to other areas, okay? So AR, we want to evaluate, we want to react. What are our current balances? Is this sufficient? What can we infer from our data? How can we prevent claims from going to 90 days plus? Where do we have opportunities to prevent that from happening in the future, right? Again, we're looking at this RPO model and we're applying it now to AR the same way we did to denials, but we're coming up with different things. So for example, we recommend now changing your AR buckets, and instead of looking at things in 0 to 30 and 31 to 60 and so forth, to shorten that period. Now, the reason we look at that is because most people don't know, but the 0 to 30 and 31 to 60 days, those 30-day buckets, those were originally put into place because that's how long it took for the mail to get to the payer and to get back to us. We no longer have to send our claims in the mail. We're sending them electronically. And in most cases, we're getting that response back in the first 14 days, or we're getting that response back within 30 days. And it is not common for us today to look at buckets like this. But many of our practice management systems allow for us to look at these shortened bucket periods. Sometimes, let's say we have a patient who is seen, right? We submit their claim and we have the wrong insurance, but we don't know that. We see them again at 31 days for their next visit. And then we finally go into review in AR at 60 days and see, oh, They were denied way back here. We were notified here, but we didn't look at it until they got into our 61 to 90 bucket. There's no reason for us to wait that long. Now the patient's been seen again and we still have the wrong information. So that's another one we know we have to appeal. We need to be looking at the information sooner, right? This is what we want to do with our react, prevent, and optimize. Don't just look at the way we've always done things. We really, really want to shake it up. Again, there are some case studies in here for you that talk about things that you can do to change, ways you can use best practice to improve on your AR recovery. And we can do the exact same thing with contracts, okay? RPO, what are our current contract negotiation strategies? How are we managing contracts after they're signed? What are the terms in payer contracts that are causing us challenges? If we measure our contracted allowables, are our fee schedules too low? Are our fee schedules too high? What should we carve out? When you start looking at things in an RPO model, what you're really doing is drilling into the information you need to know to continuously improve your revenue cycle. And you should be looking at these areas in this RPO at least annually to improve your revenue cycle strategic plan. We want you to do the same thing when you look at reporting strategies, okay? Most people have report strategies for what they're looking at month end, what they're looking at on hold. When we look at the RPO for it, look at what reports you have that are already canned and what data you're getting from that. What reports can you create that are custom? What technologies are we not fully utilizing? Again, you see, we go right back to what are we not fully utilizing, right? We want to make sure we're putting strategies in place that help us drive success in these areas. So we've included for you, again, I know there's a ton of resources, but I hate when I go to a session and I don't get any. We've included for you in here examples, right? What should you be looking at month end? What are the closeout activities and reports that we want to look at? And when we look at these items, does this signify a great dashboard that we could put together and view for quicker digestion of the information, right? Where are those opportunities to optimize? There's also recommendations for reports we don't want you to forget to take a look at, okay? So reports on hold, reports of claims that were pended, right? We want to make sure that these don't get missed on timely filing because they were pended and never returned to. We want to look at trending payer receivables, right? We want to look at all of this information because it's going to eventually drive our KPIs and how we build our KPI dashboards. Now, however you build your KPI dashboards is going to depend on how you want to see the data. You know, perhaps you want different tabs to see that information. Or perhaps you're like me and you love big, colorful visuals, right? And big, bold letters. Maybe this is what speaks to you more. Or perhaps you have a really detailed dashboard that covers everything. And when you sit down with your providers, you just go block by block and talk through each one. What you're seeing here are all of the KPIs that you spend all of this time pulling the information together on, pulled into one sheet so that all the effort that you're doing can be seen visually for them and easily digested, right? There are a ton of industry tools that are available for you to use. You'll see that we have links in here for industry tools. We have links to industry trends. What we want to make sure that you're doing is documenting the strategic plan and using technology as much as you possibly can to help support your efforts. So for that end, we want to make sure to include some industry trends while you're working on your strategic plan. Make sure you're including workflow reengineering. When you optimize technology, it's going to change workflows. It's going to alleviate some areas and burden some areas. Health equity, staffing, COVID-19 recovery, the end of the PHE, payment parity, cybersecurity, right? All of these are components that will help to complement your strategic plan. So you want to make sure those are included. So now that we are at the end of this presentation, I want you to think back on what your philosophy is. how your revenue cycle model is unique, and how your strategy is set up to benefit your customers, because all of these are driving forces in how well you're going to succeed with that strategic plan. I did not see any questions come through. I don't know if I just can't see any questions come through, but if you have any, please feel free to message me or Kim. We present together separately at times. If there's a question and I can answer it, I will answer it. So please feel free to reach out.
Sure. Thanks, Erin. Well, welcome back, everyone. Hope you had a nice break, got to refill your coffee, and your email's not exploding. We appreciate you joining us. My name is Melissa Kwiatkowski. Just a brief intro. So I've been in the healthcare industry for the last 13 years. I'm actually a healthcare banker at KeyBank. I'm a CMPE since 2013 and also sit on the board of the PAMGMA. We thought it was important, so I'm a forum rep for continued education for PAMGMA. And we thought it was important just to share some of the updates that have occurred this year for certification and fellowship. And, you know, if you're considering enhancing your education through board certification or fellowship, please know there are a ton of resources. Whether you visit the MGMA website under the member community, please reach out to our board here of PAMGMA. They can connect you with me directly, and I'm happy to talk with you one-on-one and share what's available for you. So let's start with the first slide. There were two changes in board certification. So under the application pathways and then also for continuing education. So if you look at this slide, it shows you what the first two pathways were. And then on the right, the third, what's changed. So you still need to be an active MGMA member in good standing, purchase and complete the application. What's new is you do not have to have a bachelor's degree. So if you have 6 years of healthcare experience, and of the 6, 4 in healthcare management or in a healthcare leadership role, that allows you to start the application pathway. So that's definitely a nice change to pursue the CMPE application. And Erin, if you want to go to the next slide, this touches on your continuing education. So there's no changes to complete your board certification. All applicants, you have 3 years to complete requirements from the purchase date of your application. You have to complete 2 exams and earn 50 CEs. What has changed is once you're accepted, you can add continuing education hours up to 3 years prior to your application purchase date. So I think that's a nice enhancement because it encourages, you know, you to continue to complete the certification in a timely manner. So that's an enhancement for 2022. If you want to go to the next slide, Erin. Some differences with the fellowship. So to complete the fellowship, you want to demonstrate knowledge in the body of knowledge, demonstrate leadership, innovation, and strategic planning skills to achieve desired business outcomes, have professional engagement for the next generation of healthcare leaders, and demonstrate a commitment to CEs and professional development. So there are 2 pathways now for fellowship, and you still have to be, you know, current MGMA member, hold the CMPE in good standing, bachelor degree and 5 years of healthcare experience, or master's degree and 3 years of healthcare experience. The timeline has not changed. So, you know, you have 6 years prior to the application purchase date. But what has changed, and I want to make sure I'm on the right slide here. Let's see. So what has changed is you can hold the CMPE designation for at least 6 years and complete 25 continuing education hours pertaining to leadership. So those can also be included in CE hours used to maintain your CMPE. So the previous pathway was, doing your business plan, facilitating university or coursework, advanced education programs, formal presentations, author or co-author of industry-related book or articles. That is still a pathway. Or, as a CMPE, if you have held that designation for at least 6 years and you complete 25 CEs, which can also be included towards your CMPE, that is an additional pathway to fellowship. So that is a change for this year. And Erin, you can go to the next slide. So again, this just kind of highlights the volunteer hours that are still required. Complete 6 volunteer hours, 3 must be healthcare related, not limiting to industry related organizations such as the MGMA or ACMPE. And if you want to advance one more time. So again, this just kind of highlights the changes. The volunteer hours are the same. So, and there are other programs as well within the MGMA, the certification programs. So if you've seen on the website the certificate or certification programs, that's something that, whether it's in human resources, financial management, operations management, you can earn up to 14 CE hours through the certificate programs, which also count towards your CMPE. So again, this is just to call attention to the changes. I know that we're going to touch on some other elements here. I'm happy to address any questions that anyone has, or we can, move on to the next speaker. So I know we're starting a little bit early. Angela, are you ready?
Yes, I'm ready.
Okay, so our next topic is on value-based care, and we're happy to have Angela Court. Angela is the practice director at Komen and Kimmel Family Practice, which is a division of Genesis Medical Associates. She's been in healthcare since 2002 and involved with the PAMGMA since 2019. She just recently joined the board. Angie attended Butler Community College and then continued to receive her bachelor and master's degree in healthcare administration from Robert Morris University. She's very active in her local community and a national member of the MGMA as well. So Angie, the floor is yours.
Thank you so much, Melissa. Hi, everybody. Good morning. You can go ahead to the next slide. So I'm here to talk today about transformative healthcare delivery and just more of a quality-based approach to healthcare and how we can expedite that and change our practices in our everyday life. So what is the definition of transformative healthcare delivery? It is the transition from fee-for-service models to more of an integrated value-based healthcare service delivery model. So value-based meaning that we want to keep our patients healthier longer, and that adds more value. We can go to the next slide. So we're going to go over some transformative healthcare delivery and shared savings today. Next slide. So how can your practice make the switch? You start to realign the way that the care is delivered to your patients. It's one slow step at a time. You can't just decide, okay, we're switching from fee-for-service to value-based healthcare. It's a couple years in the making. You're no longer looking at the way to treat the diseases. We want to try to prevent the patients from getting diseases. So we're taking more of a proactive approach. We can do this by simply focusing on some different things with our patients. Instead of switching our focus to getting all of our patients in the office and being seen and making money off of every visit that they have, we want to switch to more of a quality or preventative focus. So we want to focus on our preventative and wellness visits. That could be in wellness visits, well child checks for little kids, it can be everything. We want to focus in on our vaccinations and making sure that people are getting vaccinated for, tetanus, their Prevnars when they hit 65, and then all of the preventative screenings, giving them the cardiovascular workup to know what their risks are if they don't make changes. Chronic care management and monitoring of the tests that we order within our offices, and following up to make sure that the patients are receiving those tests in a timely manner, and then how we're going to treat that. We want to focus a lot on medication adherence. We have a lot of patients who don't spend their time doing medicine boxes or things like that. They're trying to manage a bunch of pill bottles. So by having somebody focus in on their medication management and adherence and making sure that the diabetic person is taking their statin to prevent the heart attack, things like that really make a big deal for our patients. And then emergency room and inpatient transition of care visits. Anytime those patients are leaving the hospitals, the facilities, such as skilled nursing or long-term or short-term rehabs, for that kind of thing, we want to make sure we're having visits with their PCP to kind of close those gaps to prevent readmissions. Next slide. So let's talk a little bit more in depth about preventative care, vaccinations, and preventative screenings. So all of your patients in your offices should be receiving either a yearly physical, a well child check, or an annual wellness visit. By checking in with these patients once a year, it really helps you to stay connected with them, to close those gaps, to find out if anything new has happened. People go into the hospital, have their appendix out, and their PCP wasn't knowing for years and years until they decided to go back to the doctor. Or people are utilizing urgent cares now for their sick visits instead of calling their PCP. Not only does that cost the patient more money, but then that also costs your practice more money. So we can definitely prevent people from utilizing those if we stay connected with our patients. We can also use these visits to complete our health screening. So I said earlier, we have the cardiovascular screening. We can do depression screenings and checks. Mental health is just as important as their physical health. It's all about these visits, staying up to date with our patients and closing those gaps. The next slide, please. So chronic care management and monitoring tests in patients. Chronic care management is a great way to stay connected with your patients that are super sick, that have 2 or more disease states, such as like hypertension, congestive heart failure, or diabetes and congestive heart failure. Chronic care management is a way that you can do monthly outreaches to your patients via phone. You can even do this in addition to remote patient monitoring with like blood pressure cuffs or scales, different things like that. It's a way that you can have somebody from your practice call and check on your patients. Your patients then feel like they're getting an extra hand put on them to help them close their medications, to reconcile their medications, to figure out if they're taking their stuff right, to remind them, oh, well, the last time I was at the office, Dr. So-and-so wanted me to take my blood pressure every day. I've been forgetting for the last 10 days. So somebody calls me and reminds me. So now they take it for a couple of days. It's simple things like that that make the patients feel more appreciated, more part of their own healthcare, like that they have a say in what's going on with them. So chronic care management is a great way to do that. Also, it is a billable code. So you have to be able to reach your patient for 20 minutes, and then anything more than 20 minutes after certain increments, you can bill that. So we have lots of information on that if anybody's interested. The next thing with monitoring your tests and your treatment. So you should have a method of keeping track of any imaging, any lab work, any referrals that your physicians give to your patients, so that you can then, if let's say they want it done, you should have a way in your EMR. In our EMR, we can put like an end date or a completion date in it. on the test so that it will then flag us to let us know, hey, you ordered a colonoscopy for this patient 2 months ago and they haven't had it done. We can then close that gap because we've been alerted that this patient still hasn't had their colonoscopy or that we didn't get the result. So we can call the patient and say, hey, Mr. Jones, you know, Dr. So-and-so ordered you a colonoscopy 2 months ago. I don't see that you've had it. You know, you can read that tells the patient that you're following up with them. It's giving great patient care. So then the patient can say, oh yeah, I didn't have it. You can offer to help schedule them and get them in, or they'll say, oh, I had that last month at X, Y, and Z hospital. We can then outreach to that hospital, get that copy of that colonoscopy and close that gap for that patient. And all the while the patient is feeling that extra set of hands on top of them, taking care of them and being part of their healthcare. So it's really important to have some kind of monitoring of your tests and your referrals and your imaging. Next slide, please. Medication adherence. So this is so difficult in the era that we're in because medications cost a lot, insurance costs a lot, and we know that inflation has increased. What do our patients do? But stockpile their medicine. They go to the hospital gives them their medicine from the pharmacy, so they go home and they have an extra week's worth of medicine. That patient's not going to throw that week's worth of medicine out because it costs them money. So they're going to stockpile it and utilize it later. Then they have all this medicine stockpiled in their kitchen or in their bathroom, and they don't know what to do with them. So at some point, you got to say, okay, we got to throw this medicine away. One of the ways that we can do the medication adherence is by doing, as soon as they leave hospitals, ERs, nursing facilities, a medication reconciliation within 30 days. There's a code that we can drop to let insurances know we're doing that. But we can also work with the patients on specific quality measures that most insurers build for us. One of those being getting a statin for a diabetic patient and making sure that they're getting refills timely so that we know that they're taking it to try to prevent any kind of as much cardiovascular disease as we can for our patients. There's also the kidney disease monitoring that goes along with that. And we get urines on them to make sure that they're getting stuff and taking their medication for that. We can obtain this data through your current insurance or insurances that you're contracted with, or groups from pharmacies. If you work with certain pharmacies in your area, in your respective area, you can reach out to them and they can give you lists each month of patients that are yours or fills that have been done that have not been filled in a couple months. That really helps to close those gaps and keep those patients healthy too with specific disease states. Next slide, please. Okay, so this is a big one. Emergency room and inpatient transition of care visits to prevent readmission. So some of the places in the United States, the readmission rates are so high. We have to be very careful in how we can create keeping those lower. One of those ways that we have found, and at Genesis, we have an entire team built just for this, is we see patients within 7 days of getting discharged from the emergency room or a facility such as a short skilled nursing facility or the hospital. Seeing the patient sooner is the key to keeping that patient engaged, following the correct plan of care that the doctors have given them, and keeping them out of the hospital. So transition of care visits can be done 7 days and 14 days. I will tell you that the statistics are much better. If you get that patient in within the 7 days, the readmission rates are so much lower. If you can't get them in for whatever reason, they can't do telehealth, they can't drive, you can at least do a medication reconciliation phone call with them and build that out. And that can be done up to 30 days. This part is really important. So at Genesis Medical Associates, which is one of the groups that I'm part of, we actually have an entire quality team built around this specific thing. We call it the TCM, or Transitional Care Management Team. We have a nurse or an MA that watches our hospital discharges every single day, watches our facility discharges, and then sends a group message out to our providers saying, Mrs. Smith was discharged from the hospital yesterday and she resides at this facility. Can you please complete the TCM? So then our doctors know that one of their patients at the facility was admitted, which wasn't always happening for us before, because the patients would come back to the facility, they're feeling better, the facility's taking care of them, and we kind of drop to the bottom and they forget to tell the PCP. So by creating this team that's watching and following your patients in the hospitals and out of the hospitals and the facilities and the emergency rooms, it's a really great way to close these gaps and keep these patients from getting readmitted. Next slide, please. So the last subject we're going to talk about is the shared savings. This is an alternative payment model for healthcare providers. It's based on the amount of money saved by treating patients. So it's normally something that you contract out with either your ACO, or which is an accountable care organization, or your insurance payers. You can build a contract that gives you different tiers or different levels of reimbursement for closing different quality gaps, for lowering your readmission rates. These are usually defined by your insurers. But again, at Genesis, we have a whole team. It's a quality advocate. We have an entire department of quality advocates that just work our list from our payers, because there are so many different payers, and from our ACO, to make sure that whatever our patients need to have done, to make sure that we're preventing as many diseases as we can for them by getting colonoscopies, by catching stuff early. That team-based approach works so much better within the realm of healthcare. So we currently have like a quality advocate, a medical assistant, a scribe that fulfills the note-taking part for the provider, and the provider as one team that cares for each set of patients. Next slide, please. Value-based purchasing is widely favored, throughout the U.S. healthcare system. Again, this is about quality. You're choosing several quality indicators and you get financially incentivized, but the providers are by the insurers to make sure that the patients complete those quality indicators. And not only is this a financial gain for the providers and for the offices, but it's just good patient care. Your patients feel like they're getting outreached more, they're making sure that they get their tests done because they know how important it is. And again, we're really focusing on preventative care. Next slide. Erin, I don't know that I can see the chat. Do you have anything?
No, that's okay. Melissa, do you want to, there aren't any questions at the moment, Angie. Do you want to move us along, Melissa?
Yeah, sounds good. Thank you so much, Angie. Enjoyed your presentation. Our next topic is patient care portals and the ACMPE exam. We're delighted to have Tracy Evans present to us. Tracy's been in healthcare for more than 41 years. She entered healthcare management in 1995 and then joined the MGMA and PAMGMA. She has worked at the Mount Nittany Physician Group since 2010, and she is the immediate past president of the PAMGMA Board of Directors. Tracy's given her time frequently and generously over the years, and she is also a certified fellow. So with that, the floor is yours, Tracy.
Thank you, Melissa. Welcome, everybody. The approach that I took with the presentation was to do a little bit of background on just the body of knowledge and how frequently that changes, and then to delve into this very broad topic of transformative healthcare delivery, which Angie has done a great job of covering a lot of those topics today. But just to give us a little background, the body of knowledge is based on separating things into domains. And we had a certain set of domains in 2013, and they were reevaluated and changed just a little bit in 2020. The previous domain that is now transformative healthcare delivery was patient-centered care. So it's a very broad topic, and I think the transformative healthcare delivery really brings a lot of the technology items into play for us. But the percentages on the CMPE exam also were adjusted a little bit. I think they tried to make that as reflective of what is important in managing healthcare. Next slide, please. So the keywords, and this came right from the MGMA website, are a lot of broad topics for the domain. And as I said, Angie covered quite a few of these different things. If you are looking at sitting for the certification exam and you look at a domain that has this many broad topics, you may feel a little bit overwhelmed. But if you familiarize yourself with the topics that are included there, you'll realize that you know more about the broad sense of transformative healthcare delivery just by doing your regular job. So we have talked about a number of these different things, a lot of the different programs that are available, and just what I'm going to highlight now a lot are the patient portals, especially, and things going together like patient portals and telehealth. When the pandemic hit, people were really scrambling to get those things online. And I think we were not as far along until the pandemic. And then we had to make those adjustments and did have some help with some of the rules being minimized a little bit to allow us to do that. Patients were much more agreeable to telehealth visits because it was one of the only ways that we could offer care. One of the things that with patient portals, most EHRs have a patient portal available for patients. Sometimes equal to requirements on patient portals are that it has to be easy for the patient to use and offer different things for the patients to be able to really have to be able to push like amenable to those things. Now that we've experienced the pandemic and they've had to be had to connect electronically, I think the patients that have taken advantage of using portals really like them. I know in our experience in my practices, patients will really use the messaging through the portal to be able to get messages through to their providers. And sometimes they do overuse that a little bit. So you have to set some parameters around it. But I do think that it's been very successful. I think another challenge with patient portals is the connectivity issues that you may have in your geographic area. Our area here in central Pennsylvania is a pretty broad range. We have people that have great access to high speed connectivity. And then we've got patients telling us that they only have access to dial-up. So that's pretty broad range. And sometimes you don't get patients that really want to engage. So you really have to sell the benefits of the portal and try to do anything that you possibly can to get those patients to engage via the portal. So this is just going back to looking at the broad range of transformative healthcare delivery and separating that very broad topic into 4 sub areas: care models, payment models, organizational models, and innovation and emerging technologies. And as I said, Angie spoke about a number of those different things with value-based care and alternative payment models. And this is also an area that is evolving all the time. So no one is going to know absolutely everything about this domain, and just familiarizing yourself with those topics is probably going to be adequate for being able to prepare for the certification exam, if that's the approach that if you have decided that you do want to approach certification. I want to give you some tips or tricks that you can use to prepare for studying in such a very broad area, such a broad topic. So how do you know what to study whenever it's such a broad range? Again, I've said familiarize yourself with the material. Take a look at all those different areas of focus and ask yourself, how much do I know? How much do I utilize some of those things in my practice? My specific experience is that I have always been in the surgical specialty realm. I have not been very involved with primary care initiatives. So I know what's happening and I'm involved with it, but not on that in-depth level. Whenever our group first formed, we were still working with meaningful use. And we did have all the managers across the entire group involved in how do we develop workflows that will be implemented in all of the practices, specialty, including, not only primary care, but all the specialty practices. And we implemented those workflows. We still maintain most of those to this day, just because they make sense. But the focus now has shifted a lot to our primary care team, and they are the ones that really are digging into some of these models and implementing things. And whenever it does translate across to the specialty practices, we implement everything across the board. So familiarize yourself, concentrate on learning more about the areas that you may not use in your particular practice. You can always search on mgma.com and talk to colleagues who may be subject matter experts. If you feel that you don't know enough about PCMH, reach out to someone who is in primary care and might be able to help you understand that topic a little more in depth. Just a reminder of the available resources that are right at your fingertips on mgma.com. If you go into the website and just start doing some searches, you will find information on almost any topic you could think of, and you're going to find it in almost any different way that information can be shared. Some people want to be able to sit down and read articles in order to digest their information. Other people want to participate in webinars. Many of the webinars that are available on MGMA are even on-demand webinars, which really helps a lot with being able to study during off hours when you're not at work. There are podcasts available that you could listen to in your car while you're commuting to and from work. And then there are also research papers. The business plans that people have submitted for their fellowship requirements are all online there. All of this different material is available to you for studying and becoming familiar with the content that could be included in the exam. So this is just in the slide, you can't see it very well, but trying to show you the member community that is on MGMA. I will tell you that as I was preparing this and I wanted to get in, I had already prepared the slide and I was going back and trying to look at things. It was under construction. So they were making changes to the member community. So I wasn't actually able to get in and look for some of the things that I wanted to look at. But it may be back up and online by now. I haven't looked for a couple days. The member community is available for anyone who's a member of National MGMA. And if you don't know anyone personally, you can get on there and look at different threads that have happened in the past and search that. The information might already be there, or you can start a new one, a new conversation, just reaching out and posing your question to the community, and people will respond. You will get to learn names of people that are subject matter experts, and you can reach out to them. Everyone is usually very willing to help. You also can reach out to other members of Pennsylvania MGMA. We try to engage people through social media all the time. We have an active Facebook page, Twitter, Instagram, all those different methods now. Using technology to communicate and to learn has probably not been easier. So there are a lot of different ways that you can connect and learn, and should be able to find a way that would work for you. So I had this so that we could give an example of a couple of questions that could be on the certification exam. Unfortunately, the answer popped up there, so that doesn't really help us very much. But this was actually taken from the former domain. Those were the questions that I was able to access, and this was on the from the domain that was transformative healthcare before, which was patient-centered care. But the question, which of the following is not an effective method to improve patient care performance? Surveying patient satisfaction, training staff on issues raised by patients, assessing the outcomes of patient care, or tabulating no-show trends over time. And the answer is tabulating no-show trends over time. That isn't going to weigh into transformative healthcare. So we can go on to the next slide. I give an example of another question. I'm just a little bit, my connection's a little bit slow. So the Joint Commission on Accreditation of Healthcare Organizations, JCAHO, is an organization that defines quality standards for which of the following? Health plans, nursing homes, hospitals, and healthcare organizations, and individual physicians. And of course, the answer is hospitals and healthcare organizations. It's kind of right in the title. So if you weren't familiar with the Joint Commission, you could probably easily still answer this question correctly on the exam. So I've heard this said a lot of times as people are contemplating taking the certification exam, and it actually is a quote from Dr. Benjamin Spock: "Trust yourself, you know more than you think you do." And that I think you can see from those last two questions, or just looking at the broad topic of transformative healthcare delivery, you are using a lot of those things in your normal workday, and you're familiar with those things, probably familiar enough that you can successfully answer questions on the exam. And then I wanted to just also remind us from a quote from Mr. Spock: "Logic is the beginning of wisdom, not the end." So I hope that this has been helpful and encouraging to anyone who might be considering sitting for the certification exam.
Erin, it's Melissa. I just wanted to mention too that, since we're on the topic of certification, the MGMA is launching a new certification and continuing education portal on September 28th. So more information to come, but essentially the portal will be one central place to track anything pertaining to ACMPE. So any of your continuing education credits, to review your credits, and also complete applications. So more to come on that.
So come on, let's see some faces. So we're gonna have an interactive dialogue here, and if I call you out, then I know who's gonna yell at me. So come on, turn your videos on. Let's participate. Let's make this engaging and interactive. I've got some 1, 2, 3, 4, 5 major topics to talk about, let alone what you want to talk about. So last call, everybody. If Michelle Burris can do it, y'all can do it. Let's go. Open up your video. Okay, really? There we go. Okay. We've got
All right.
Paul, there we go. We're cooking with gas now. Let's go.
All right. Peter, I'm working on it.
All right, Ben's working on it.
I'm
Okay.
working on it.
All right, Heidi, Jean. And there's
I
some
don't see the spot to do it in.
Yeah.
You don't, up on top on your computer where the camera is?
I think you have to be invited as a panelist for that to show up.
I'm fixing
Yeah.
it.
Come on, guys.
Because I was looking for it too,
Yes.
and then as soon as I got invited to be a panelist, then it showed
No,
up.
All right.
yeah, kind of.
Can
All right,
I
so
get
Erin,
that?
let's make everybody a panelist so we can
Yeah,
see our
there you
faces.
go.
There we go. Here we go.
All right.
We're
I need
cooking.
I need that panelist button.
All right, it's coming. Hold on. Erin's making you a panelist. We're
There
getting
you go. Join as a panelist. Let's see what happens.
All right, there's Jean. You're in. Okay, so it's not you or your computer. It's not technology. We got you. There's Heidi. We have an unlicensed room. Doesn't that sound like, I don't know, in healthcare, like, I don't know, like something we shouldn't have? Ben, there you are. Now unmute yourself.
All right, Peter, you see me, you can hear me, right?
Yes, we're good.
There
to
you go.
There he is.
Technologically challenged.
Ah, you're good. But really, the unlicensed room name just sounds like, I don't know,
Yeah.
really eerie
We're,
kind
we're-
of
we're
thing.
not in
healthcare.
compliance with something.
Yeah, really. It's like, this is the book I show the IRS, from The Godfather, and this is the book I don't show the IRS. Well, hello for whoever's in the unlicensed room. I can see you, and hello to all of you.
It's me, Peter, Tracy.
Oh my gosh. Tracy, what are you doing that's unlicensed?
Well, see, I don't know why it says that, but I'm at our corporate building because I'm off today because of this. And
That's
I
probably
didn't
why.
trust that my dog wouldn't bark during my presentation, so I thought I'd be safer to come here, so. I'm challenged by this a little bit though.
And these are the challenges that continue, right? Like there's no end in sight, even though we want there to be. So anyway, I am Peter Constantino. I'm the executive director of Pennsylvania MGMA. I'm glad to see faces here. I'm sorry that we're still doing some things virtually, and I really do hope sooner than later we can get together in person. But I want this to be interactive, and that's why I was busting on all of you to show your faces through the cameras, because I do want this to be interactive. I used to be a practice administrator, so I gave it up for Lent, though, some 23, 24 years ago. Yeah, I did. I just said, enough. Like, why are we making this harder than what it needs to be? But we were also employed by it, so you got to balance that one out. But I want to spur some engagement here amongst all of us about some of the challenges and the opportunities that we're facing. I know there's a lot that, you know, Taya talked about, and I've known Taya for, I wouldn't say how many years, but for a long time. She looks better than I do. And I hope you found her session worthwhile. And for those of you who couldn't attend, I know Erin is recording, and we'll make those available to you. So I know you talked about revenue cycle management and staffing and training and turnover and denials and claims. And I know we were talking about transformational healthcare and this telehealth and value-based purchasing and such. But I just want to go around the room here, and if you could tell this group, forget me, I'm just going to facilitate, your top 1 or 2 challenges that you're facing today in your practice. It could even be literally today versus, you know, coming out of COVID, still in COVID, soon to exit COVID, whatever we want to call it. So Michelle, I'm going to start with you. 1 or 2 challenges you're facing right now in your practice that you can definitely share with us.
Yeah, I can share. Biggest issue we deal with on a daily basis across the entire practice, regardless of department, is staffing and then compensation to replace staff, and then getting the board to understand why we have to pay more money. That's the biggest consuming topic. It really sometimes keeps me from being able to get to other operational things because I'm just always dealing with it. And our HR person is tired because all she does is recruit.
Okay, we're going to come back. I'm not letting you go. I'm making my list here. David, how about you?
Which one? I'll go.
Oh, sorry, David Chimento. I'm sorry. I forgot we have 2 Davids. It's like a board meeting. Okay.
You know, I'm going to echo what Michelle said. So staffing is a huge challenge for us right now. Staffing and recruitment that goes along with that to ensure you keep staffing. And then compensation, it's got to be almost every day that I hear something like so-and-so's, you know, paying $20 an hour to flip burgers or do whatever. Why can't I make that? Or, you know, this large health system is paying $22 an hour and I'm making $18 an hour. Mm-hmm. Why am I here? You know, something like that. So it's difficult to keep up with the trends. And we've given significant increases to most groups of staff over the last couple of years, but it's just difficult to keep up.
Okay. David Regan?
So I'm one of those big health systems, or at least, you know, a small part of it. But not surprisingly to me, staffing's a challenge too. We have open positions that we struggle to fill and to keep filled. I think a lot of it has to do is it's a little bit on how much it costs, although we have probably an advantage over some, you know, more typical private practices in terms of what we can do for benefits. But again, it has to do with the complexity of the work versus, you know, flipping burgers. And that's really, people are doing the value proposition here and saying, okay, well, I get more, I get it. That's nice, but you know what? This is so much more simpler, and I go home without a headache. And you know, I'll take that other option. And so, you know, I think it's you know, it's a demanding job, and so it's not just filling it. It's also how do we engineer it or use technology or do something to make the job a little more humane for the people that sign up.
That's a good point. Good point. Okay, Heidi.
Staffing, I'm fine. I just had 1 open position and it was newly created. So, but it's the compensation. I echo David. You know, my staff is throwing in our face. Well, I can go down to the street here. We've been in business for 51 years. We're an independent practice. So we fight against the big boys. And my staff say, well, I can go down the street. I can make this and that. We have a very healthy, robust benefit package. But sometimes my salary, the pay, can always compete against the bigger kids on the block.
Right. Okay. Jean?
We're in psychiatry and we are slammed with patients every day. We turn patients away. One really sad thing is we just take the big insurance. We take Blue Cross, Medicare, United, Aetna. We don't take Cigna. We don't take Medicaid because they pay horribly. I mean, it doesn't even cover the hourly salaries of our nurse practitioners. Well, I need help negotiating my contracts with the payers. And I mean, we're small. We have 11 practitioners here, but it's small. And when I've tried on my own, they say, well, you're in the Philadelphia area. There are many, many other alternative people that they can go to. Well, there aren't. I mean, we turn people away, and it's very sad because they say, can you refer me to someplace else that is taking patients? And we're like, no, sorry. So I've asked Paycom before I mean, at some of the Florida meetings, I remember people being there who said, you know, if you need help, you can hire us, we'll negotiate for you. But I can't remember who they are or where they are, and I really do need help with that.
Okay, I marked that. Kathy?
Oh, and I have to duck out at 12 and talk to a patient, but I'll be right back after she leaves.
We'll let you back in, don't worry, absolutely. Kathy?
I'm gonna pretty much echo what everyone's saying. I guess where we're really having a hard time is that in order to attract, you know, the people, you're paying a little bit more than what you did, you're giving higher raises, but we can't, you know, what patients don't understand, and, you know, they say just raise your prices. We can raise our prices, but we're not going to get any more. And I don't see anything in, you know, like that insurance companies are taking into all of our costs of supplies and our personnel costs and our benefit costs when you're updating the fee schedule. I'm not seeing that from what I'm looking at the preliminary reports. And it's like, oh, we can deal with this if we can get, you know, compensated for the additional cost, but we can't. And that's, I think that's the biggest challenge.
The payers are not like the IRS that adjusts the mileage reimbursement rate, you know, depending on, you know, what's going on in the world.
Yeah, and I think that the other problem I see is that people can't handle what they used to be able to handle. Like you need more staff to do the same jobs, so that you used to be able to do for whatever reason. And whether it's just the stress of the environment of working the last few years, but it seems like we need more people to do the same thing. So not only are we trying to stay on top of what we need, but we're also adding more.
Okay, Paul?
Well, you know, the whole issue of staffing, I could also echo that, but just for the sake of bringing up another topic that's related to it that Kathy touched on is how so many vendors have increased their fees for supplies, for services. And I'm sure everybody's received either letters or emails saying, you know, due to inflation, we have to raise our prices 6%, 7%, 8%, whatever it is. They're all raising their prices. So it obviously affects the bottom line because we are, as Kathy mentioned, you know, we are all on fee schedules that are not having any increase. So in addition to the staffing challenges, it's just the operating expenses related to all of the services and supplies that have increased this year that weren't really budgeted for. So it makes having any kind of positive bottom line even harder.
Tracy?
Yeah, more of the same. Staffing, that's huge. And also compensation, because one of my big challenges is getting my HR department to really understand that the challenges of hiring someone in a physician group environment when you're part of a health system, because they are hospital-based. I mean, that's where HR started. That's what their experience is. So they're offering sign-on bonuses for MAs or LPNs and RNs, and they do hiring events for the hospital. But even though I've asked for hiring events for us and for them to look at what are they going to offer for my entry-level registrar schedulers, nothing. And they can go to Sheets and get tuition reimbursement and make more money than what we're able to offer. So, you know, and then when you do think that you've hired someone, getting them to continue to show up for work. I've had 2 people, one person worked 1 day and didn't show up the rest of the time. And the other person worked 1 week and then resigned over the weekend via email. Her husband got a promotion, so it doesn't make sense for her to work anymore. Didn't work out a notice, didn't do anything.
Can I just jump in here? I don't know why this is, because I've always had trouble hiring people, but this year I hired 2 great nurses off of ZipRecruiter. I've never had luck with Indeed, and they just keep charging you like crazy, but ZipRecruiter worked out great for me this year. I don't know why.
Oh, wow, that's great.
Thank you for sharing that. And Ben, how about you?
Well, I guess I'm on the other side of the scenario. Unlike all of you, I actually run a medical billing company. So we support practices that have in-house billing teams. So when you ask, you know, what type of issues are we seeing? Actually, almost all of the ones you guys have mentioned, but if I had to pick 1 or 2, contracting issues is one we see, and also credentialing issue with providers are the ones that seem to get in the way of efficient securing of reimbursement. So I was particularly, obviously, as you can imagine, interested in Taya's first presentation, because we wanted to improve how we can assist our clients. And so I learned a lot from her presentation, some of the things we were already doing, but there were certain things that we can assist in making things a little bit better from a cash flow revenue reimbursement standpoint.
And Melissa, how about you? I know you're in a different industry, et cetera, but still, what are your challenges that you're facing in the course of a normal day?
Sure. I certainly hear all of the challenges that you all shared from clients. In my world right now, a lot of it's set on, economic conditions, rising rate environment, the cost for materials. So a lot of folks, all finance transitions, for instance, and there are a lot of folks kind of looking to maybe retire or sell earlier than they had thought, just kind of given everything that's, that occurred over the last 3.5 years. So all of that kind of mixed together presents a challenge. And then just the staffing is hindering, the efficiencies that happen in practices. So just looking to be like more efficient, and even me with my time, my world has gone from being on the road and meeting with people in person to everything's virtual now. And so, how do you try to be as efficient as possible and kind of making that work. But yeah.
I'll share with all of you, and we'll go into some of this because I've been taking notes here. So my wife works for Johns Hopkins Pathology at a satellite office. She's a med tech. She's in her 36th year. A few years ago, they were short tech, so they made her a lead tech. Not something she was really looking forward to do, but she was certified and they did. And down. And so as I said, she's at a satellite office closer to home, doesn't have to pay for parking and so forth. Downtown, unfortunately, in Baltimore City, crime is on the rise. Every day there's always a security alert about somebody who is either being attacked or carjacked or whatever that's going on, and it's every day. And she gets these messages, primarily downtown. The core lab on their day shift is short 50 people, which is huge for those of you who, Angela, you got it. Okay, I've been watching you. I'm watching you. My eyes are on you. I got you. I got you. Unmute yourself and then we got you good. And we're going to get to you. But they're short 50 people. And just recently they announced at the satellite office that one of the major providers of specimens and so forth for the work that she does is actually thinking of opening up their own lab. And behind the scenes, they've been working with Johns Hopkins, her employer, to actually do that. And potentially as early as November this year or January this year, which means that if there's not enough workload for the two, there used to be 3 people on staff, now they're down to 2. And if there's not enough workload for the 2 of them, or that they don't have to work weekends anymore like they do, they will send them downtown to help fill up the slot. Now my wife's going, my wife has done this, she right out of school. They trained her at Hopkins and they hired her right away, as did her coworker. And they're both like, why would we go downtown, pay for parking? It's further away, mileage, gas is expensive, whether it's 30 cents more or $3 more, it's still more. And so why would we do that? And they're gonna have to work more weekends than they would because they're short so many people downtown. So she's, dealing with those issues going, I don't need to be a lead tech. I've done this long enough. I'll give it to someone else. But then that would knock her down to a bench tech and would require her to go downtown. And so they're all dealing with this. At the same time, Johns Hopkins does not pay as much as their next door neighbor, which is the University of Maryland. And so they did an analysis, 30 of the 50 open positions, it's because 30 people went across the street to University of Maryland where they were paying a lot more money than what Hopkins was. So related to this for a second, just to keep it together, yesterday I went to get lunch at Wegmans across the street behind me. And this lady's there going, you don't have to wait in line here. And I was only second person at the deli counter, and it was 11:55 in the morning. She said, don't do our call up and you can pick up to go and just come over here and we'd have it ready for you. And I said, well, why are you pushing this? Because I've never been to Wegmans that they've done this. She said, we're down over 50 people. She said, look over there. So in this Wegmans is the deli counter. Next to the deli is the pizza. And next to that is the coffee bar. I didn't realize it. There was nobody behind the pizza counter. There were 3 trays of pizza pies that were out. This is at 11:55 before lunch in this area here. I mean, that is huge. There's usually like 10 or 12 different pies and there's a whole lot in the oven. They had to find 2 people from another department to get ready for the lunch hour rush. And then the coffee bar was dark. They have nobody. She said, it's been shut down for over a month. I went, you can't do that. People need their coffee, for God's sakes. What are you doing? And she went on to say there's 50 people shortage. So I told my wife last night, not as a smart ass, but being, smart versus smart ass. I said, honey, go work for Wegmans. It's closer than Hopkins. They pay more than Hopkins. It's one of the better places to be. You may not get tuition reimbursement. You'll get all the benefits and we can manage, through all this. And my daughter is at college is going, Mom, do that. Free food or discount on food, especially after yesterday's announcement that food increased 13% over last year, right? So I'm not trying to make fun by any means of the situation we're in, but try to lighten it up because it is very difficult. And I know a few of you said that it's hard to get the work done without hiring more people. And I found it on our side too. I know Erin's muted, but one of the things that we talk about is our workload is increasing because our association leaders all have day jobs and they're all busy and they can't dedicate more time to the association to get done. So they're looking to us to take on more. We've had to hire more people, and yet my costs, and that was something else that we talked about, operational costs are going up because of inflation, energy, mileage reimbursement went from 56 to 62 cents, a mile. I mean, that's huge if you're traveling. So I get your pain, albeit that that I gave up healthcare 23 years ago, but I feel your pain. And I want you to know it's not just in your industry. Unfortunately, we're seeing it across the board. And the effect of the great resignation, the great retirement, the COVID deaths, and inflation and so forth, and burnout. I know Jean had a call with a patient, but I'm sure she can attest to what she said before, is burnout and the mental stress that everybody is undergoing, including ourselves, and some of us may try to mask it. We're tired emotionally, mentally, physically. So my question now is, and I know there's no magic wand here for the answer, is with staffing, recruitment, compensation, and costs going up. I think, Paul, you talked about operating costs. Have you initiated anything to reduce costs or reassess costs? Do you even have time to do that?
I can just give one example of something that we did that reduced our telecommunication costs. And many of you maybe have already done this, but we were still on what I would call a more antiquated phone system. And I'd for a long time been wanting to move to a voice over IP system that would also enable our staff that are working remotely now, because we have a lot more staff working remotely, to be connected via the same phone system. So we did implement that change, and I'm not making a plug for the one that we used because there's a lot of good ones out there, but I don't mind sharing the name of the one we went with is Ooma, OOMA. And it definitely has decreased our operating expenses related to telecommunication. So if any of you have looked at that as maybe an area where you would want to reduce expenses, there's a number of really good voice over IP phone companies out there. And the nice thing about the one we work with is it's just a month to month. There's no contract. So if at any point we wanted to switch to another one, we could. And it was not too difficult to actually port the numbers over to them. So where you might have, like, say, a Verizon bill, now you don't have a Verizon bill. It's all through this voice over IP company. So I just wanted to share that because that was a success that has definitely reduced our phone or telecommunication costs.
I'm going to ask if anyone else had an opportunity to assess any operating costs that were rising and make any changes, even over the course of the last couple of years.
Peter,
yes.
One of the things that we just implemented, I guess, in July was, with staffing, when COVID hit, we started calling all of our patients that had appointments and doing the visit, all the pre-visit work, history, physical, medication rec, all of that over the phone to limit the amount of exposure to, our staff and doctors and things of that. And also to keep people, once they get in the waiting room, they can go back and the patient is seen quicker. So it really is working nice, but it really was took up too much time. So we implemented a company called Mozart, and it does the phone. It does all of that over the phone with questionnaires, but it's much more user-friendly than what our EMR had. So it will call up the patient, they answer the questions, and then it imports it directly into our system. And their price was reasonable. Some of the other ones were not, and that's kind of why we never really did it, or they didn't do the demographics and the patient information. They just would do one versus the other. So we're kind of working through that now, and patients are utilizing it, and we're just kind of figuring out how we can kind of now maybe it's not as time consuming for our staff, and if we are down somebody, we get the work done still. So.
Very good. That's efficient. Anyone else? That's good. Yes, David.
Hey, Peter, this is something we did pre-pandemic, not necessarily in the last year or two, but something that might be helpful to look at is your answering service. We were using an answering service provider was a local provider, and found that PerfectServe, which is a national provider for answering service, really reduced our costs significantly. I will say like 20 grand a year in just answering service providers. So something to look at.
Cool. Absolutely. Anybody else want to add to this list of cost savings of some sort?
Hey,
We looked at
Peter,
oh, sorry, go ahead.
oh, no, Angela, you haven't spoken. You go ahead.
We looked at the vaccines that patients, how they're covered within their insurance plans and things. Like, we found that we were paying up front for like Shingrix, which is not truly like a high expensive vaccine, but the reimbursement to get that covered by Medicare is a little harder because it gets covered more, and their copays and their deductibles are lower if they get it through a pharmacy versus
Right.
getting it through their physician's office. So we had to go back and reevaluate our vaccines. Like, you would think that, oh, well, a vaccine should be given by their PCP at a physician's office, but that's not always the case. Actually, we found that it saved us money and our patients money by giving them an order and having them go to the local pharmacy to get some of the vaccines. Now, not all of them, but Shingrix was one of those ones.
That's interesting. And it's amazing for what's you typically would be done in a doctor's office. But I also have a friend who's a pharmacist who said, Peter, your doctor won't get reimbursed as much as we are and will find it harder. And so for the last few years, I've been just going to the pharmacist and she gives me the vaccines that we need. And the doctor's like, yep, just send me the paperwork so I have on file. You got your vaccine.
Yeah, it's crazy.
Yeah. Ben.
Yeah, I just wanted to comment on Paul's comment about the voice over IP phone network. It's interesting he mentioned that when we started our company, actually this was pre-pandemic, we actually set it up so that our folks could work remotely, but they could all be tied under one phone system. And so it has worked fabulously well. It's very flexible. And like Paul said, monthly subscription. The one we went with was GoToConnect. I will say this for those of you that are looking at that, there are a number of voice over IP phone companies. Actually, my background before starting healthcare was in telecommunications. My wife really is the healthcare expert. She always reminds me. If you're going to look at voice over IP phone networks, make sure that they have a excellent technical support department. Okay, that's key, because there's a lot of them out there, but technical support may not be what you'd like. So if the technical support is up to speed, then that solution will work out well for you. If it isn't, you'll save money and you'll hate the day you went to it. So I just want to add that as a advisory.
We use VoIP in our office. We used RingCentral originally when we came into the office, but they got to be very expensive. And then when COVID hit and we were doing Zoom licenses, and they went from say 2 million users to 200 million users, they had to build up their infrastructure. Once they got it stable, we found a cost savings going from RingCentral to Zoom and purchasing all our stuff there. And I mean, their technical support has been very good. And our staff, I know I'm in the office, but for only a few more months, and then we're downsizing and we've been remote for the last 3 years, and we'll continue probably to be that, except to have a place for like event preparation and things of that nature. But we moved to Zoom. That cut our costs tremendously, and everybody can just download the app if you don't know it already for VoIP on your phone, and it masks your cell phone number to be the office number. And in the past, where you needed multiple numbers, you just need one phone number and then just multiple extensions, and that's all you're paying for. So I mean, if you're not on VoIP, that's certainly been worthwhile to look at. So we talked about telecommunications use of voice over IP. We talked about with Ooma and others, answering service about PerfectServe, cutting a substantial amount of money from David's expenses. We talked about vaccines. We even talked about you doing pre-visit work over the phone. And I ended with that one because I want to go to something that I think it was that Jean mentioned earlier, which was about ZipRecruiter. What are you finding as, I don't even say we can say the word the best anymore, but what are you finding as useful to find employees? And is it through the means of, Monster.com, Indeed, ZipRecruiter? Is it more by word of referral, you know, for your existing employees and I'll say a finder's fee or something paid to them. What are you finding as helpful, let alone potentially the best? Heidi, you unmuted, and Melissa, forgive me, did you want to say something before? I saw you unmuted yourself and did I miss you?
Yeah, the only thing I was going to add, just because again, my background's different. So, you know, something to always look at is processing fees, like card processing fees. You would be surprised, you know, especially if they sync up with your, or integrate or interface with your practice management system. There are other companies out there that do that now. And I mean, the volume of credit cards, HSA cards that patients pay with, you know, given the dynamics, that's just always something to review every year. You know, your current processor can review those and sometimes offer savings. And then other times, you know, you could look at other vendors. And I would guess that that's a big part of patient receivables is cards now. So
I spend
Thank you.
almost probably $3,000 a month. It's just in credit card fees.
wow. Yep.
Wow.
Yeah.
Are you on a flat fee for regardless of the card, or are you on a
No.
discount fee per card?
Discount per card, but we process. I mean, I'm sure David pays more
Yeah.
than that. He's a large, Genesis is bigger than us. But we process that amount of credit cards. That's all of our co-pays when they come through the office.
Mhm.
If they call this is the admin office here. So if they call the admin office and pay over phone, or go to our patient portal and pay through the pay online. So, but yeah, it's about $3,000 a month I'm paying.
So
Wow.
do yourself a favor. I'm not saying what, I don't know offhand. I know in my field what's available, but I know it's available out there. And as Melissa said, go call the banks in town and the processors, because they all use the same thing. They use First Data. They, you know, there's a handful of processors and they all use it. It just depends who has a contract with whom. But what you can do is go to your bank right now and go to a couple of banks and just say, I want an RFP. I want a submission for a proposal for these number of, give them an idea of your average number of transactions and the dollar amount per month.
Oh,
The
yeah, I
reason-
can give them reports.
Yes, so the reason for that is, you know, we're always hearing the fluctuation of the discount based on the card, and American Express is the most expensive, and then blah, 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 right? However, there's so many, some of the banks are, I wouldn't say all of them, but some of the banks and some of the potential credit card processors that are out there are leveraging the volume of their clients to like First Data and the processors. And they're coming up with like, I'm just coming up with a number, 3% discount fee, maybe 25-30 cents per transaction. And if you did the math, especially with your higher discount cards, if you saved $500, I'm just making up numbers, $500 a month, that's $6,000, which is a major expense. And couple that with some of the other things we've talked about, that's a major cost savings. So they want your business, they need your business, because that's how they make money. So just say, you want it, you need to work for it. I want a flat fee. And I will tell you, in our industry, and we have it across all our clients, AffiniPay is a credit card processor. And I don't know how you can tie into anything you're doing. It's just something that does tie into our systems. And they are at 2.9% per transaction, regardless of the credit card used, and 30 cents a transaction. And on my highest association, which included sponsorships, so like $5, $10, $15, $20,000 charges, they saved about $5,000 a year.
Wow.
So they're supposed to work for you, not the other way around. So leverage and say, do you want this volume of charges in your system? Because that's how they make money. Then I need the best rate. Now, I know Melissa works for a bank, and we're going to be careful about what we say about banks and so forth, and financial institutions and such, but they're supposed to work for you. So leverage it to your benefit. Seriously.
100%. And there's, you know, there are other ways too, that things that they don't tell you, and I'll share with the group, but even like phone transactions, like you're paying almost double to key a card in over the phone versus if you
Swipe
save
it.
a card on file. So if you have reoccurring patients based on your specialty, take that HSA card or credit card or debit card, save it on file. So if they do call in to make a payment, you're paying a cheaper rate. So there are all kinds of tips to save, but that's just something simple from my perspective that I can share with the group to look at cutting expenses.
And to ensure that you don't you don't violate any PCI compliant, that you're in PCI compliance and you don't violate, you find a processor that keeps the credit card, not you. So it's on them. The onus to protect the credit card and all the security of the information is on them, not you, because it's a minimum $10,000 fine for every credit card you have on file if it's unprotected in any way, like somebody wrote it on a Post-it and put it in their desk drawer. It's at least a $10,000 fine and so forth. So you want a processor that can take recurring payments but maintain that information to get it out of your hands.
And HIPAA
So-
compliance as well. So there are processors that are PCI and HIPAA compliant. So you do want to make sure if they're storing, because that's considered patient data.
Right.
Okay, so let me ask a stupid question, and maybe Melissa will cringe if I ask this. Every quarter I have to do a PCI compliance. So is that telling me that my processor is not work?
No, so there are two ways. You can pay a fee. So there's a fee that you can pay every month, and essentially the processor will do that for you, or you can elect to do it yourself.
Oh,
Yeah, so
it's
there
been
are
many moons since I set it up. So and
yeah.
before
if
the
you're-
pandemic, so I don't remember.
Yeah, that's something you could look at. So your current vendor, I mean, if you're doing something every quarter, I don't know how much time you're spending on that.
It's not much unless there's a hiccup with our firewalls, or if I add something
Okay.
new, then it wants to say you did this, and then I have to go back to my IT team.
Okay, I mean, it depends. It's some vendors will do it and then it'll add, I don't even want to say the number, it could be $20 a month on top of your fee. And then essentially they're doing it for you. And then once at the end of the year, you have to do a certification with
Yes.
them.
Well, I already
Okay.
do that too.
Okay,
Right.
so it sounds like that you're doing it, but you're probably saving like 20 to 25 a month by you doing it. So that's again, another time savings of how much time does it take you to do it versus if you paid that $20 out. You kind of have to weigh,
Okay.
what's of more value to you.
And for all our clients, when we weighed this out, I'm just telling you, we said all of that onus is on you. I'm not doing the reports and so forth, and they do it all, and it's built into 2.9%, 30 cents a transaction fee, and it's it. And what's nice, we used to use authorize.net. They have a minimum fee of $25 a month if you
Yeah.
don't hit, right? This one is not. I have clients who don't use it because they're cyclical, and in those months, there's no merchandise credit fees, processing fees at all. The account is still active. It's not like due to inactivity that you're lost. So do the RFP, make them work for you. I can't say exactly what's available, but I know this stuff is out there because the tables have turned. And we don't have time to do this stuff. So you put the onus and say, do you want this money coming into your processor? Yes or no? Because that's what they need. They need that. That's how they make their money. So if they want it, make them work for you.
Got it.
Cool. Anyone else? So we're potentially cutting telecommunications, we're cutting answering service, we're dealing with vaccines, processing fees, and pre-visit work. I mean, depending on your practice, we may have saved you about $35,000, $40,000 on this phone call. So why aren't you paying your $125 Pennsylvania MGMA dues? Anyway, I'm just being a little smart there. I had to do that. But we were asking though, thank you, Melissa. I apologize that I cut you off there before, so I appreciate that discussion. But I do want to go to what are we finding as a better way to find employees? Is there a better way to find the employees versus the Monster, the Indeed? Is it through word of mouth?
Well, I just would put a plug-in for Indeed because I have found success with that, and I know that it's not the cheapest out there. But what I do is I set it up so that I'm not paying any monthly fee. I'm just paying for when I need a position. And then the nice thing about it is you can set whatever your budget is. And I like the fact that it has given us a lot of candidates. And when I'm interviewing them, I can pause it so that the job is, not bringing in more candidates than I can handle. And then as soon as somebody's hired, I just can turn it off again. So there is definitely expense involved, but I find that the software is easy to work with, and it's definitely proven effective to bring in a number of qualified candidates for us.
Is anyone using LinkedIn to find candidates?
I've posted PA nurse practitioner jobs on LinkedIn, but not your frontline candidates.
Okay. I will, the reason why, oh, I'm sorry, go ahead, David.
I've had success from that as well for those types of jobs.
Yeah,
Right.
I would think LinkedIn would be for your higher mid-level physicians, things like that.
Anybody. I will tell you that I have had various, and I don't have all the hierarchy and the expanses as you have in your practices, but over the years, I used to use Indeed. I was horrified at some of the, even with, criteria in place, it just horrified at some of the documentation that I received. And one of my employees said, did you go put it on LinkedIn? Because number one, you can assure that they would have to have a profile in order to be able to see it. And you can set up the same types of criteria. You have to be within a geographic area. You can set up criteria about how many years experience, whatever you need, and you post it for free. If you want to add money, similar to what Paul, you were saying about Indeed, if you want to go and spend money because you want to broaden the reach or, what have you, you can spend that money. We have found all levels of employees through LinkedIn. I've been pleased with it. I will just share with you the one pre-post-COVID caveat. Pre-COVID, I would post a job, and I kid you not, in less than 6 hours, I'd have over 24 candidates. I'm not saying they're all good, but if I found, 6, and then I had my top 2, I was thrilled. And and the most I spent pre-COVID was $75 to $100 to boost it on LinkedIn. During COVID and post-COVID, I've only posted free because I did a couple of jobs with a boost. I had to go as high as $250, and the most candidates I received was 5 after 2 weeks. And that's because the other 5 that said yes to the job were, even though they saw a hybrid Hunt Valley, Maryland, they applied from other countries, even, and so then LinkedIn realized, like, okay, we need to get people who aren't in your country to stop applying for the job, because it's, yeah, we can do things remotely, but I can't help somebody that's halfway around the world. And so they were building in those features, but that's the only difference, was the volume of people that would apply. It's less. And there's some quality people that are out there. So I just throw that out to you is in terms of staffing, but I think it's all a crapshoot right now, because it's a matter of something somebody said before, which is the ease of job versus the pay and the benefits that you're willing to pay me. I joked, but it was true. When McDonald's eventually opened up over here, they gave a $500 signing bonus for a cashier. I really thought of doing that just to get the extra $500 as a signing bonus. Like, it's sad, but that's what's going on. And the question, and I know it came up before about compensation and how we throw money at it, is how much more can we throw at it without hurting the company? Yeah, we may have saved $30,000 and all the stuff we just talked about, but we can't, if we spend 35, we're in the hole 5. And sometimes spending the 35 is because you've hired somebody, and Tracy said it, in a day they left, a week they left. Now you have to go and rehire, and you have to retrain, and there are costs in there. So is anyone else finding anything beside Indeed, ZipRecruiter, and or LinkedIn to find employees?
I've used Facebook ads for jobs recently. And at first I had some luck, but I will tell you, with the most recent time I did it and paid significantly more just to boost several open jobs, I did not have any luck. I got a couple of medical assistants that applied for it, nothing for front office, nothing for scribes, things like that. So it's really hit or miss.
It's getting tougher on all these platforms. Anybody else want to share?
I just saw something, and I haven't had a chance to look at it. It just came across my desk, but it's one of the organizations that certifies MAs. And we only hire MAs that are certified or are, just out, if they're out of school, they're eligible to be certified. But it looks like it's some sort of program where you can train them in your office. It's like it's an apprenticeship to certification. So I'm not sure. I'm going to look at that. I mean, because MEs are one of the hard things to do, to see if there's like people that you might want to promote up but don't have the schooling, and if there's a way that we could develop an internal program to try to, have a bank of MEs in our office. So that's something I'm going to look at, but I haven't had a chance. It just came across my desk this week.
Oh, anyone else? Thank you for sharing that, Kathy. So I know, we still have a few more minutes, even though Taya's there, because that's her little indirect nudge to me. Peter, I'm getting ready to come back on. But we're talking about staffing and compensation. I do want to ask this, because this came up in our conversation, is how are we handling our own mental well-being, let alone that of the staff? And I don't mean that we're at burnout, but clearly everything has taken a toll. Michelle, I'm going to pick on you for a minute. How are you handling it? I mean that sincerely.
Well, I drink more than I did. And I'm only half joking. More often than not, I go home and have a glass of wine. But I tell you, the weekends have become so critical to me, and not trying really hard not to work on the weekends, because I'm worn out by the time I get to Friday at 1. I'm done, like stick a fork in me. But so I have become more protective of the weekends and try not to do things and come back here. And then, I come back a little bit refreshed on Monday, but by the end of the week, it's just brutal, because the reality is myself and the leadership team is picking up all the slack from the staff that are not here. And so all of us are feeling exhausted by the end of the week. So honestly, I haven't gotten a good answer, except I am protective of my weekends and trying to disconnect in a way that, like tomorrow morning, this Saturday, I'm going crabbing. And I'm trying to do things like that where I'm outdoors. I can't touch the computer because I'm not near it. So it really helps me, at least for those 2 days, I can stop for a moment. But that's the only thing I do. At the end of the week, I'm exhausted.
Mentally, it's like you're worn out.
Yeah.
Yep. Anyone else? Drinking, remember the disclaimer from Pennsylvania MGMA is, one glass, maybe one glass too many. So please take it under advice of a proper medical clinical or clinician. Paul,
Peter,
I think,
yeah.
go ahead.
Well, I just wanted to mention that I think it was a few weeks ago that there was a speaker that kind of talked on this very topic.
Yes.
And that was a very good session. So if that's available in a recorded format that could be sent out to everybody, I would recommend it, because she did a great job of really touching on a lot of the increased pressure that a lot of us are under, and some of what she was describing, I really felt like she was talking directly to me in terms of just trying to balance work and life. And I think that some of the points she made are similar to what you said, Michelle, is making sure that you really do unplug from work when you're off, and to try to get outdoors more. Just, taking, even during the day, taking a brief walk, sometimes just getting out from behind the computer and the desk is important. And one thing that I picked up in the last year that I've really enjoyed is playing pickleball. So I don't know if there's any other pickleball players out there, but it's been a lot of fun and it's a social thing. And I've enjoyed looking forward to doing that sometimes in the evenings and on the weekends.
I want to comment quickly. Erin, I think it was a collaborative webinar that we had that Paula was referring to. And dare I say, with this group, based on what Michelle started off with about drinking for her mental well-being, I think what we probably should do is have a re-showing of the collaborative webinar, but at like 5 o'clock in the afternoon, so you can bring your glass of wine or beer or whatever it is that you would like and learn about how we can disconnect, but while drinking. So
Do that.
yeah, I think we should. I think we would get like 100 people that would join that one. Yeah, come join us for a happy hour and learn how to disconnect. Bring your bottle of wine. Anyone else want to add to this? I just, and I'm looking around. I just want to say this. There were a lot of, I took the list and I have my notes and I will share them with Erin so that we can, include them in the follow-up for today. Number one, I want to leave so that everybody leave the session with all of you knowing you're not the only one in this boat. And it's not only healthcare. Whether that makes you feel better or not, I don't know, but it should make you realize you're not alone. The people that are on this call all express very similar, if not the same situations that we're facing. And the strain or the pressures on what's going on economically in the world, which definitely affect compensation to our employees, the benefits to our employees, and also the costs to us and our employees, in gas and food and everything else. The pressures are enormous there, and we all know the root of a lot of the evil, I call it, in terms of stress and just our psychological well-being does come a lot from social interactions and financial issues. And so I don't want anyone on this call to think that they're alone. That, I hope, is what you get out of this, and that sharing just how we do telecommunications, answering service, vaccines, things of that nature. I know in my past life, I'd be like, oh yeah, okay, if I only had time to think about it. Well, at some point you have to, because it'll be for your well-being and also for the well-being, not just financial well-being, but just the well-being of your practice. Yes, I know we've heard everybody say times are changing. I don't think we know what the new post-COVID, whatever we're going to call it, monkeypox introduction era is going to look like. And I'm not making fun of any of those things, just to add a little brevity here. But nobody knows what that new norm is going to look like. What we know is that some of the things we did during COVID were right, and some of the things we did were wrong. I know I'm not getting political here, because there was no book on this. I remember the first day that the governor of Maryland shut down the state, and I told my staff to go home, and we were on our first Zoom call, and Erin's as my witness. I said, if any of you have a better way of doing this, tell me. My textbook on management philosophy in the 1980s had nothing about pandemics and shutdowns and things of that nature of the magnitude that we've faced. None of it. And I said, so if you've got a better way of handling it, I'm all ears, because that textbook I know I don't have, but I didn't have anything in it about this. So I think what we have to do, though, is following some of Michelle's advice, and I'm not referring to the drinking side, but the disconnect side, to really say what works, what doesn't work. Keep doing the thing that works, enhance that, whether it's staff morale, compensation, whether it's efficiencies in the practice, whatever, because that continues to lighten your load, mental, physical, and otherwise. And then take some time to say, maybe I should consider sending certain patients for certain vaccines to the pharmacy instead of going nuts in my billings and claims department trying to get paid 10 cents for a drug that costs me $50. I'm making things up. You have to do that. And so I don't want you to think that any of you are alone in this. That's number one. Number two, there are very simple, practical things that we can do. And the key is share. So as I close out my session, I want you to not stop the sharing once this session is over and once today's virtual program is over. David, Michelle, Kathy, and Melissa and Paul and Angie are all on the Pennsylvania MGMA Board of Directors. If you have thoughts, comments, opinions on how to keep this dialogue going, it doesn't have to be all day, obviously, how to create that sharing, tell us. Because you know what, after a while, sometimes we're a little, like Michelle said, we're worn and we don't know the right way to get you what you need. So I have this list of staffing, compensation, ease of job, recruitment, stress, quantity, the quantity, number of employees we have to hire, patient care issues, payer negotiations, cost expenses, contracting, credentialing, the whole economics issue. I have all those here. If you want to talk more about them, Pennsylvania MGMA would love to continue that dialogue. We just need you to participate and get the word out to your people, to your network. But don't be afraid to do that outreach, because you're not in it alone. As I said earlier, you're not the only industry. I think Erin and I, speaking from the AMI team, we missed our holidays. I don't know where the holidays have gone. I know they came, but I didn't disconnect either through the cord or through drinking, but maybe that's what I need to do, because sometimes it's hard to disconnect in that off time. But if you don't, you're going to wear yourself out. So on a positive note, I thank all of you for participating in this call. I hope some of the topics and the information that we shared are helpful to you. If one nugget you can get out of this is to make sure all your vendors are working for your good, whether it's in merchant services, whether it's in supplies, whether it's vaccines, whether it's EHR, whatever it is, make sure they're working for you. You're not working for them. If they want your business, they will do what they need to do. They all know how to do it. Look, we're doing it. We're figuring out how to rerun our businesses in this new age. And it still hasn't set out or settled yet. So any last comments for the good of this group before I get kicked off and you go on to somebody who is much better at speaking to all of you with words of wisdoms? All right.
Peter, I just want to thank you for making sure that we all got on our cameras and being interactive. Really, I thought it was a great touch, and you made a virtual session almost feel like it's in person.
Well, I'm glad. Thank you for that. I know, look, I'd love to close the curtain, as I call it, but, you know, opening it up, it just makes me realize, look, you're all working in the same type of area that I'm working in, and I've got my piles. I may not have them on camera, but I have my piles. I've got my headaches. You have them. You're not in it alone. And poor Tracy's in an unlicensed room. So you can only imagine what's going through with Tracy in an unlicensed room. So turn on your cameras once in a while. Make yourselves vulnerable and just realize that you're not in it alone. So with that, I thank each of you for participating in this session. I hope you again got even just one nugget of information that you can take back and use for your good, individually, professionally, or for your practice. I see her camera is not on yet, but she will, is Taya Moheiser. And I know you were talking, some of you were talking about her session this morning. And I said, I know Taya for a long time, but she looks better than I do. And Taya is just, and she and her counterpart, Kim Tolliver, are just two phenomenal people. I want you to, you'll have their contact information, reach out to them. They have a wealth of information, and sometimes some of the things that you need are right there in front of you, but we don't always see it, and you know it. You tell you tell your medical practitioners, this is what we should do. This is what we should do. This is what you should do, right? Michelle's laughing because she knows where I'm, Michelle, you're up my upper left-hand corner. And you tell them that for 3 years, and they say, you know what? I think we need to get a consultant in. And then they pay a consultant to come in and I said, we think you should do this and this and this. And it's like, let's do that. And there you are going, now I really need a drink. I've said that to you for free for 3 years. And now you're following your advice. So please use Taya and her partner, Kim, to whatever extent necessary, and keep that dialogue going. There's a wealth of information there.
Hello, everyone. Welcome back. It is just after 1:05. Hope you all enjoyed your quick 15-minute break. Looks like we're ahead of schedule here, so it's great. So up next, we have Taya joining us again. And something that we didn't mention earlier was that Taya also holds her CMPE credential and was at one time very involved in Maryland's MGMA chapter. She's also the former president of the HIMSS Nebraska chapter and is a 2019 Midlands Business Journal 40 Under 40 Executives and Entrepreneurs Award recipient. So welcome back, Taya.
Thank you so much. The introduction part is always awkward, I think, for whoever's being introduced. They just kind of have to sit there and nod. But I very much appreciate you doing the introductions. And I appreciated getting to see Peter for a second. It's been far too long, far too long. So I am going to turn off my video while I'm presenting in direct opposition of Peter. But if you have a question at any time, we weren't able to really get the chat working right. So if you have a question at any time, please feel free to turn your camera on, unmute, raise a hand. Open conversation is always going to be more engaging. And I love talking about anything legislative. It's why I'm on the Government Affairs Council. So we have less content for the 60 minutes. I can talk a little bit slower, but I also really just want to chat and make sure we're answering any questions you guys have. So with that, let's go ahead and dive right in. And what we're talking about is preparing for the end of the public health emergency. So we're going to talk about reviewing changing regulations. We're going to talk about parity training, new telehealth guidelines. We're going to do a sneak peek at the proposed rule. And I'm going to give you some contact information for who you should reach out to if you have specific questions with CMS. Oh, thank you, David. So everybody can put their answers in there. It looks like I missed a lot while I was gone. So yeah, please feel free to post in the chat. There have been a lot of changes, and there's a couple things we know and a couple of things that we don't know. What we do know is that the PHE is going to expire. What we don't know is when. So with that, let me go ahead and skip past. Again, if you need my bio, it's there for you. Please reach out to me at any time. Let's dig right on in. So the COVID-19 public health emergency, we don't know when it's going to expire. We do know that while we've been in this emergency, a ton has changed, right? The CARES Act, Paycheck Protection Program, the Consolidated Appropriations Act, American Rescue Plan, HR 1868, protecting Medicare and American farmers from sequestration. All of this legislation has been enacted or passed either in relation to COVID specifically or just happened during this public health emergency. So this first went into place at the end of January in 2020. Most of the world shut down kind of around mid-March. You know, I think I was at the Financial Management Conference for MGMA speaking one week, and the next week we were supposed to be at HIMSS, and HIMSS was canceled. And I remember thinking, wow, if they canceled HIMSS, this must actually be serious. Right? It has continued to be renewed, this public health emergency, every 90 days since then, and it was last renewed July 15th. The current expiration is October 13th. Now, the news that we have from the Hill is that we are going to be given a 60-day heads up prior to expiration or termination. That language is a little important because what they're saying here is, though it's set to expire on October 13th if it's not renewed, if they were going to let it expire, we would be notified 60 days ahead of time. Now, they could renew it October 13th for 90 days, and they could decide 30 days into that renewal that it's going to expire within the next 60 days. So just keep in mind that it's 60 days is really the notification we're going to be given. Even if we get a 90-day renewal, we still need to be looking out for that 60-day notice of expiration. So when we talk about all of the stuff that's changed during it, and thinking about what happens after the public health emergency, we really need to look at, what was life and practice life like before the public health emergency, what changed during it, what is sticking around and what's not sticking around, right? The CARES Act suspended sequestration payments. It increased Medicare payments for inpatients. We had a ton of funds, just a ton of funds injected into the industry that they're not looking at having injected again. We've got some additional extensions of suspensions of sequestration payments. The PAYGO was delayed, thank goodness, but we're looking at that coming back into effect, right? And then we're looking at increased physician payments to make up for the suspension or the delay of the sequestration payment adjustment. So there's a lot that's taken place here. KFF, if you haven't been out to their site, they've got a ton of information on exactly what all has changed in the last 2 years, which is helpful for us to look at to understand what do we need to evaluate with what we need to change going forward, right? So if you look at the funds that were injected into the industry, this is a ton of money, right? We're looking at $178 billion of total funds that was pushed into this industry. And some would say that's a lot of money, especially given how high cost this industry already is. But when you look at the day-to-day management of practices and facilities, this was what we needed just to stay afloat, right? And we have the Great Resignation, we have people resigning all of the time. It costs more to bring new people on board. We have all the costs associated with higher medical supplies, with putting in COVID PPE and re-navigating patients, and how they check in and where they sit in the waiting room and how far apart they're spread out and all of those resources. And that all cost a lot of money. So did shifting people to work from home. So this is a lot of money that was injected. We don't anticipate to see big funds like this to be continued to be injected in relation to the public health emergency. But we do still have some things that are going to stick around in relation to the pandemic. So we really need to dive into what we know is staying and what we know is going away. So really to take a look at that, let's start off with what we know, okay? We know that the pandemic, the public health emergency, the PHE, can only be renewed in 90-day increments. That's a statutory requirement. That's why they haven't said yet, okay, let's just keep it going all the way through the end of the year. That's just something they can't do. So they have to renew it in 90-day increments. They did tell us we're going to get that 60-day heads up from HHS before termination or expiration. If you don't currently look at your MGMA Washington connection, start reading those documents when they come in, right? We have a great team on the Hill. I'm part of the Government Affairs Council that meets with them on a regular basis, but we have a team that is on the Hill every day talking to legislators, trying to impact change. And the second we are given that heads up, we're going to get notification from them. They're also very active on social media, on Twitter, on LinkedIn. So whichever platform you prefer, whether it's your email in the Washington Connection or wherever, look for your MGMA leaders to give you that update. There are also some state level policies that will make some of the PHE regulations permanent after expiration. That's in addition to whatever's coming out from the federal level. Now that changes by state. So this is an area where you're really going to want to make sure you're engaging with your state level MGMA, which you're already doing by being on this call. So good on you, but make sure that you are staying in tune with that. What the commercial payers are going to do, we just don't know yet, right? We know that Medicare is making some changes. We know that commercial payers tend to fall in line with Medicare, but we don't know what they're going to do after the PHE, and we're going to have to wait to see that. We do know in July, this was expected to be renewed again, and it's expected to be renewed in October, potentially for the last time. The reason we have more concern about when this is no longer going to be renewed, or the fact that it's going to be expiring soon, and the fact that we're all talking about it, the reason that's all come up is because if you look at the CMS calls, CMS has open calls and open communications that take place on a regular basis. And one of those is their quarterly stakeholder call. In January, their call was about how can we drive additional support? What do folks still need in regard to the pandemic? And in April, all conversations shifted to what do we need to do to unwind what happened during the PHE. So we know that the unwinding is coming. This has been a greater topic of conversation throughout HHS, not just with CMS. All right, so what is staying? We know that CMS expanded telehealth services for evaluation, treatment, or diagnosis of a mental health disorder. And mental health and those expansions and flexibilities we're seeing for mental health telehealth are going to stick around, okay? There are going to be some in-person requirements. So they want you to see the patient in person within 6 months of that initial visit, and every 12 months thereafter. There's going to be a modifier for audio only. And if it's audio only, again, that has to be the patient's request or the patient's inability to do video telehealth. It cannot be the practice's desire or decision to be audio only. That has to come from the patient. But that is going to exist, that ability to provide telehealth for mental health services beyond the PHE. But that's for mental health only right now, okay? OTPs will be permitted to furnish counseling and therapy services via audio only after the PHE. Again, there's going to be a service level modifier. And right now, this is only for mental health. When we talk about what's going away, there was a 6.2% increase in the Medicaid FMAP, that Federal Medical Assistance Program. That is set to expire at the end of the quarter in which the PHE ends. Now, there's going to be a lot of difference in when things expire. So as we're going through this, and I'm going to walk you through how to build kind of a work list to prepare for the end of the PHE, pay attention, specific attention to when things expire, because it varies by item. So for this, that increase in FMAP expires at the end of the quarter in which the PHE ends. So if the PHE is renewed through the end of this year, the end of this year's quarter would be that both dates would be December 31st. That increase would then end on December 31st, right? So we want to be mindful of when things end. The waiver of originating site locations for telehealth services is going to expire 151 days after the PHE expires. So originating site and that expansion to care for patients via telehealth, if they're at their home, that sort of thing, that is not going to continue beyond the public health emergency, right? It's going to expire 151 days after. The expansion of that is only going to exist for mental health. Audio only telehealth services for non-mental health will also expire 151 days after the PHE expires. If you are wondering, because I have, and feel free to jump in here, if you are wondering why they didn't just do it for everything, we don't know. We have been back and forth. We've been requesting that they just allow telehealth services with the patient to be in their home to continue, particularly because this is very frustrating for patients in rural areas or medically underserved areas. So there's a lot of conversation happening, but right now this is still for mental health only. The other thing to note, vaccine administration, the rate of $40 per dose for COVID vaccine, that's going to expire after the end of the year in which the PHE ends. So if the PHE expires December 31st of 22, so will the administration rate of $40 per dose. Then it's just going to go into alignment with other vaccine administration reimbursements, which is like around 30. If the PHE expires January 2nd of 2023, then this is not going to expire until after the end of December 31st, 2023. So this is again where those expiration dates really come into play. In addition to these things going away, we also have Category 3 telehealth codes expiring at the end of the calendar year, unless they're made permanent in the final rule. And that's the end of the calendar year 2023, not this calendar year. Rural health centers, which establish temporary locations, they need to complete their 855 enrollment application. Now, CMS said that they are going to prepare to get started reviewing these again. They recommend everybody go ahead and start getting prepared to submit these. Our recommendation is to go ahead and start getting these submitted now, because CMS is already trying to start working through their backlog. If you have a temporary location and you haven't completed an updated 855 and submitted that, you may be deactivated by CMS. And if you are, none of the activities performed during that deactivation are going to be reimbursed. There's no back pay period. Telehealth payment parity is also going to expire with the public health emergency. And so is the licensure expansion, which allowed providers to treat patients in other states where the provider wasn't licensed. So if you have a patient who is in Delaware and you want to perform telehealth services and you're meeting the originating site requirements because they've gone into an office or something in Delaware and you're not in that location, you're not going to be able to do that unless you're part of a licensure compact or you have some other sort of reciprocal privileges within that state. And that is when with the PHE. So these bottom two, those expire at the same time the public health emergency expires. As if that was not enough, some other things that changed. This one we were happy about. The penalty phase for AUC was pushed back. So this is now going to begin January 1 of 2023, or the January 1 that follows the end of the public health emergency. So again, you see verbiage tied to the end of the public health emergency. Medicare is going to resume revalidations, audits, and medical reviews when the PHE expires or when there's evidence of potential fraud, waste, or abuse. So what they're really saying here is they're going to get back to it as soon as the public health emergency expires, but if they get wind of something hinky before that, they're going to look into it before that, okay? So just anticipate that audits are going to resume soon. And most cost sharing waivers for the testing of COVID-19 are going to expire after the end of the PHE. Now, this is not the full list. These are the top highlights that I really wanted to make sure that you guys know, but I'm going to take you through how to look at the full list also. Before we do that, let's chat quickly about Medicaid. Okay, so states were given specific restrictions during the public health emergency, and a lot was included in those restrictions, right? They couldn't transfer enrollees to more restrictive insurance packages. They couldn't increase their premiums. They couldn't make it more difficult for them to qualify as eligible. And if they met those requirements, that's when they got that 6.2% increase on their FMAP. And that increase made a significant difference in how they were able to provide for state covered patients. With that increase disappearing with the end of the PHE, it is expected that most states are going to take the opportunity to, again, make their programs more strict. So we had a lot of patients enrolled during that time period in state coverage where they weren't enrolled before. So we do anticipate seeing a lot of patients that will drop off of coverage, that will no longer be eligible, or that will have increased premiums that they're not able to meet, pay for, or financially, just be able to comply with. So keep an eye on what your state is doing in terms of state coverage. You may see a lot of shakeup in terms of patients with Medicaid coverage changes. Some additional information on the impact. Right now, the estimate is that this is going to result in loss of coverage for millions who have Medicaid. So what you want to make sure that your staff is aware of is that as soon as these things change, that they are really taking care to look for changing insurance and benefits, that they are definitely doing those eligibility and benefit verifications and educating patients on their benefits and any potential items that they may owe, any responsibilities that they would have based on these changing insurances. Update your financial hardship programs, make sure that all your documents are in order and that you're prepared and that you have a clear understanding on your self-pay fee schedules, that it's appropriate and that all your staff is aware of those self-pay fee schedules and any available payment plans. Because if we see this many patients losing coverage, that means we're going to have a lot of patient responsibilities. We want to get ahead of that by making sure we've had those conversations in advance. All right. Now, we talked about having a list and getting a list prepared. So in order to do that, there are some things you must review, okay? First and foremost, the 1135 blanket waiver for COVID-19. This is a hefty document, right? It's not nearly as hefty as the final fee schedule for 2022 or the proposed fee schedule for 23. Both of those are also significant documents. I recommend pulling up summary documents of all three of these, in addition to any updated state guidance or your specialty society memoranda. Pull together a pile of these documents, right, related to the expiration of COVID-19, and then we want to go through them one by one. So for example, the 1135 blanket waiver, okay? This is a 44-page document, and it talks about everything that changed: eligible practitioners, the audio-only telehealth services. Medicare keeps this document updated, so anything that's already expired is crossed out. Anything that's added, they have a notation in a different color. And I have a link here for you on the slide so you can quickly get to this, print it if you want to, save it if you want to save trees, whichever way. What you need to really critically remember is that the changes that were implemented, some of them are sticking around and some of them are not sticking around. And this document is going to tell you what is sticking around in terms of the blanket waiver, okay? So for example, those flexibilities for telehealth services beyond mental health, the EMTALA flexibilities, or verbal order and read back changes, medical staff privileging, physician supervision changes, right? We want to look at everything, because when we do what we call return to normalcy, really what that means is we're going back probably 60-70% to the way we used to do it, with a few changes. But in that time, we may have brought on new staff that has no idea how we used to do it, okay? So this document is worth the read. Go through it, tick off the items that pertain to your organization. Not all 44 pages are going to, right? So go through the items that do pertain to your organization. Know that normalcy at the state level is a conversation that's being held now. So CMS extended the time frame for state officials to complete any pending eligibility, enrollment documents, things like that, up to 12 months after the month in which the public health emergency ends. States have to begin resuming activities within 4 months of the expiration. They're also required to provide any impacted providers if certain sections of the waiver are coming to an end. Now, how they provide that notification was not mandated. So this could be as simple as they posted it on their website, which is why the responsibility is on all of us to go out to those state sites and make sure we're looking at this information. If election of the COVID-19 test group ends, if changes to presumptive enrollment ends, suspension of cost sharing, any of these factors you see bulleted out change, states are required to notify any provider that would be impacted. But again, this could just mean they posted it on their website. So you definitely want to look at that. In addition to requiring notifications for these, they're also required to notify when there's changes to fee-for-service requirements. So there were temporary suspensions, for example, in many states on certain prior authorization requirements. Extension of pre-existing prior auths is saying, this patient already had a prior auth, we're going to allow that to continue because they've already met all these requirements once, we don't need a new prior auth. If any of these things are going to change post public health emergency, the state is required to notify you. To get to a full list of what that includes, there is a link here to get to all the details about the state's requirements. There's a link there. So this is a lot of information for you to go through. I want to talk to you a little bit about what to expect to help you prioritize, okay? What you can definitely expect are audits, and audits, okay? A study that HHS did found that telehealth increased from less than 1% to almost 50%. That's not unexpected between February and April because everybody was trapped at home, right? So what they're trying to understand is this an outlier? How did this contribute to care improvement? How did this contribute to patient harm, right? So they're going to be billing and coding audits. There are going to be telehealth fraud audits. They've already started those because there's been many, many bad actors, unfortunately, who are ruining it for the rest of us by billing for services that were never rendered. We're also going to see the return of penalties for non-compliance with HIPAA. So if you were using a non-HIPAA platform to perform telehealth services, or you were working, during the pandemic, there was this whole, in good faith effort. If you were doing your best to abide by HIPAA, you are not going to be penalized. That is going to go away. Expect audits for good faith efforts with no surprises. There's going to be a review of all the provider relief funds that were put out there. We're going to be looking at OIG's work plan again, the opioid use and OTP programs. There is a huge, huge focus on mental health expansion. So expect to see audits in that area also. And the OIG work plan also states that they are focusing on emergency department E&M use and the use of telehealth to provide behavioral health services specifically for Medicaid managed care. So expect audits, and audits to come up. So how do we prepare for this, right? I told you that I was going to give you a way to prepare for this. How do we do that? The first thing to do, we're going to create a spreadsheet, okay? This sheet is going to identify the changes that impact your facility. So we talked about taking all of those documents, pulling the blanket waiver, pulling the final rule, pulling the proposed rule, getting all of that information together and looking at what's going to impact your facility, right? Once you have those documents in front of you, go through and highlight, this impacts us, this impacts us. If it does not impact your facility, you can skip over it for now, okay? There were thousands of regulatory and reimbursement changes, so you have to hone in on what's going to matter to you first. For every area of impact, you want to document what legislative act governs the PHE flexibility. You want to document your current internal process. If that process is going to work for you after the expiration, and when it expires in relation to the PHE. This sheet is going to be your strategic improvement guide. Once you've documented this for everything that applies to you, the next thing you want to do is start looking at your strategies to tackle it, okay? So you're going to use this sheet to develop subtasks and to delegate assignments to the staff. So you're going to want to add areas for details, for due dates, for remediation, have regular meetings for status updates and ensure progress to requests, right? So for example, CMS 1135 waiver for telehealth flexibility. There's a typo here. I'm so sorry. Dog's losing his mind. Somebody knocked on the door. 1 second. Sorry about that. He's 4 pounds of viciousness. He's very upset about the public health emergency. Come here. Okay. So, for example, the CMS 1135 waiver for telehealth flexibility, okay? The current process, we have interstate telehealth being provided by all providers. Is this sufficient after the public health emergency? No, this is only going to be sufficient if providers are licensed in the state where the patients reside and the care is being provided. This flexibility is expiring with the public health emergency. So we know we need to evaluate all the states where our staff is providing care. We need to make sure that we've registered all of our providers with the interstate licensure compact, and that if we haven't, that we are giving the patients in those other states to providers licensed in that state to provide care. This list of things that you have in this sheet is going to end up being very long. So it's important to involve other team members and to delegate. Let them become the subject matter expert in this particular area, right? So I'm going to assign that to Clara. And then I'm going to tell Duncan, okay, on the originating site waiver, we've been seeing patients anywhere they dial in from, regardless of location. But after the PHE, this is only going to apply to mental health for Medicare. And that's going to go into effect 151 days after the PHE. So Duncan, I want you to start putting together some education for staff, pull together materials. Once you do that, come talk to me. I'm going to review it. Then we're going to educate our team. Once we've educated our team, let's put together a quick video or something on social media, push that out to the patients so the patients understand what's changing also, right? This is going to drive your actionable activities as it relates to the expiration of the PHE. Because like I said before, though the old way is mostly what we're returning to, like 60, 70%, if you hired staff during the pandemic, so anytime in the last 2 years, chances are they don't know how you operated before. So even though you might be mostly returning to the old way of doing things, this may be the new way to them, right? So we really want to make sure we have conversations with our front desk, with our providers, with our intake specialists, our clinical support staff, our billing staff, and where possible, our patients, to educate them. All of them need to be educated on the information that is going to be critical to us staying in compliance, obtaining the information that we need to bill, and getting that information as quickly and as possible and as accurately as possible documented into our systems. Some of the most critical areas for education are going to be on the cost sharing waiver for COVID testing and vaccine information, or vaccine administration, right? Because after the PHE, when these things fall into alignment with other vaccines and other vaccine cost responsibilities for the patient, we want to make sure that's being collected at the front desk and billed appropriately by the billing department. We want to make sure we're in alignment with the telehealth restrictions for originating site and interstate performance, right? Interstate licensure. We want to make sure that as soon as we know about the public health emergency expiring, we are on top of any insurance change, every patient, every visit. If a patient has changed jobs, if a patient got divorced, got married, if an open enrollment happened, right? We want to really hone in on educating our staff and making sure they know what to do in these situations. And then any changes for fees, for penalties, for documentation, for code changes, it's critical that our staff is all on the same page, because the PHE expiring is unraveling a lot of what they've known and fallen into alignment with for the last 2 years. Now, some of this, though it is proposed to go away with the end of the PHE or stick around only for mental health, some of that is still being changed in the ongoing annual rules that take place, just to make it a little bit more complicated, okay? So first, let's talk about the difference between proposed rules and final rules. I always like to assume that everybody knows nothing, because even though most of you know a lot of this, there's always gaps in knowledge. So please don't think I'm talking down to you. I just want to make sure we're all on the same page. Proposed rules are issued by CMS or any other federal or state body, and the goal of the proposed rule is to give the public a heads up on what they're planning to do. Every year, CMS issues a host of proposed rules, and I focus on CMS in terms of these legislative calls because they have 1.4 million participating providers. They are the biggest payer, right? And every year they issue a ton of rules that impact providers, hospitals, administrative staff, reimbursement, compliance. And they give us 60 days to respond to what they're planning to do, to tell them if this is something we can live with or if this is something that's going to be devastating. Because once the final rule has been released, they don't review any further comments. So let's take a look at kind of what that means like for next year, okay? So Medicare's physician payment and quality reporting changes for 2023. That proposed rule was released July 7th. The comments for that are welcome through September 5th. That means this time has now passed, but that means we had 60 days to go through and say, hey, this is livable, this is not livable, we need you to change the following things. And now we wait. Usually it's around the first week of November that we get the final rule released. For those of you that remember, during 2020, there was a huge delay. We didn't get it until almost December. There was a lot of panic around how am I supposed to implement things with only 30 days heads up. That's never the intention. The intention is for them to implement the majority of what they proposed. That's always their goal. So if you haven't yet looked through the proposed rule to see what they're talking about changing, you should definitely go in and take a look at that now. It's too late to submit comments for this year, but this is standardly their timeline. Every July, we get a proposed rule. Comments are typically due by the first week in September, and then we know what they're going to do by the first week in November. If you haven't ever gone out to grab that proposed rule or a final rule, there's a link here. You just go to federalregister.gov. It's open to anybody. You can look for the CMS PFS. That's probably the easiest way to get to what you want. If you select this little PR button, that is going to reduce your search only to proposed rules. This R button will show you only final rules, okay? You can put in 2023. You can also subscribe to that search and say, anytime a CMS PFS anything is issued, I want to get an email. That'll notify you anytime there's a change being made. And it is the absolute fastest way to identify what may be coming down the line. Okay. A few days after release, whether it's a proposed rule or final rule, all the associations are going to start releasing summaries, just like MGMA did, just like CMS did in their newsroom. So if you pull this up and you find the final rule and you go, wow, this is 1,700 pages, I don't want to read through that, you can just go read through one of those summaries. I highly recommend, if there's an area in that summary that's really, really going to impact you, that you go back to the final rule or the proposed rule, find that section and read through the details in that section. That'll give you a lot more information. So to give you a little bit of a heads up on what's coming down the line from the 2023 proposed rule, since it does impact some of the PHE stuff that is going away, we wanted to just give you a little bit of information if you haven't had a chance to look at that yet, okay? The proposed conversion factor is set to decrease again as it did last year. They are proposing to delay the split shared visit definition of substantive portion being time only. So there was a whole conversation about how we could use history exam, MDM, or time to define the substantive portion of a split or shared visit, but that it was only going to be through this year. They have pushed that back and proposed to delay that again for one more year, giving us a little bit more time. They did propose some new codes for chronic pain management, and they also talked about expanding telehealth for more than just mental health services. In addition, there's some new changes to support quality models for specialties like oncology that have historically had a challenge finding a quality program that fit that high cost type of specialty. So there's a lot in the proposed rule. In terms of the conversion factor changes, if there is no congressional action, then this is going to be the base rate in 2023. We've been seeing the conversion factor consistently decrease. It is what it is. It's unfortunate to see, but this is something that happens through statutory requirements. So anytime there are changes made to the codes, we have to make sure that there's budget neutrality in the fee schedule. So anytime you see code changes and weight changes, like the RVU has been changed for the following E&M, so now they're being weighted higher, and so the reimbursement for those will be higher. In order to account for those increases, they're going to change the conversion factor. That is the basis of the Medicare program right now, and that's what keeps it with budget neutrality. So unless Congress injects additional funds, this is what our rate is going to be. In addition, they have changes to the geographic adjustment factors. Now, of note, there was a 1.0 work gypsy floor that was required by the Consolidated Appropriations Act in 2021. That took place somewhat in response to the public health emergency, right? That's this note that I have here at the bottom. That extends the 1.0 floor through 2023. This was meant to extend it hopefully through the end of the public health emergency. That was the intention behind that. So keep in mind that starting in 2024, we may see the gypsy floor change and go below 1.0, okay? In the interim, I have the geographic adjustment factor calculations in here for you. There were some significant changes by locality. So there's also a slide in here for you that shows you for Pennsylvania localities what the difference is going to be between the 2022 geographic adjustment factor floor versus 2023. And you can see that for Pennsylvania, whether it is the metro or the rest of, you're looking at a decrease right here in the proposed geographic adjustment factor. That is in addition to the decrease in conversion factor. So we're looking at decrease on top of decrease. So you want to keep that in mind. Now, when you go through the proposed rule or the final rule or the PHE and you have questions on, okay, I have a very specific question about how this applies to me, or I have something that I can't find a resource for. This is the other reason I suggest you go and look in the Federal Register. At the beginning of the proposed rules and the final rules, they give you the direct contact information by department for who you need to contact at CMS for more information. So for example, in the proposed rule for 2023, Michelle Cruz and Michael, I'm not going to butcher his last name, were both listed with their phone number for any issue related to payment for vaccine administration services. That means if you have a question, or if you aren't getting reimbursed properly, or you're having difficulty with documentation and things are getting rejected, right? You just reach out and call them. You should reach out to Regina Walker-Wren if you have issues billing for services with physician assistants or physician fee schedule payment for teaching physician services, right? This is very specific. When you call, make sure to let them know that you're calling from a provider's office. Those calls are always going to be returned faster than any other calls except patients. That's how CMS ranks their calls. Patients get called back first, then providers, and then everybody else. So if you are a vendor, if this is legislative, it's for PR purposes, whatever, you're going to be a little further down the list. If you are calling in from a provider office with a question, they're going to get back to you sooner. The other information that this does for you when it gives you their name, you can go out to CMS's website and you can obtain their email address if you prefer to email, and you can email these folks directly. So this list of individuals and their phone numbers is updated every single time a new rule comes out. So if you need the most current information, that's where you're going to get it. I want to give you additional resources though on who can help. If you want to review state action regarding COVID-19, NCSL has been keeping track of that across the nation. So clicking on this link, you can go in and you can look at what's impacting in Pennsylvania, what's impacting in bordering states where potentially we have other patients, or maybe we have snowbird patients and we want to know what's impacting in other down south states, right? You can click here and look at the state action. If you want more information on, on COVID statistics, KFF has a great site put together that goes through all the statistics, impacts, and regulation summaries. You can find PHE updates at phe.gov. They've got a whole website dedicated to it, and there's a provider-facing component and a patient-facing component. There's also an area of patient education resources. They've already begun auditing telehealth services from OIG. So for those of you that maybe don't know, HHS, the Department of Health and Human Services, is bifurcated into two sections. One section pretty much is full of the office of, and the other side is either the centers of or the departments of, right? So the Centers for Medicare are on one side, the Office of the Inspector General is on the other side. The goal of them bifurcating HHS is so that one side of the fence can audit the other side of the fence, right? Keep their house in order. It's really like telling your brother, your children, hey, I want you to look out for your sister, and then telling your son, hey, I want you to look out for your brother, right? You're making them watch each other. So OIG is regularly auditing CMS's services and anything that is paid out. So right now, the reviews of audits for telehealth services they've already performed are posted. Make sure you read emails. If you are subscribed with MGMA, with PMI, look at those listserv emails. It's going to become increasingly important as we get closer to the expiration. And I would be remiss, and I would not be me if I did not just flat out give you links to resources. So there is guidance from Medicaid that was given to the states on how they should unwind PHE in their states. So if you want to look at the guidance that Medicaid sent to each state, you can read that information here. If you want to look at Medicaid spending and what they're anticipating is going to happen in 2023 and how that's going to impact Medicaid enrollees and beneficiaries, you can dig into that at KFF, and they will let you drill in at the state level. CMS has their fact sheet on the calendar year 2023 proposed rule. So when you're going through that waiver, you're building your sheet of what you need to work on. You can dig into the things that are going to impact you in the proposed rule right here. If you want quick recaps on the proposed rule or post-pandemic flexibilities, what's going to stick around, MGMA has those resources. So if you're an MGMA member, I'm assuming you are if you're on this call. If you're not, you should sign up. If you are a member, you have access to these two resources. They are quick, they are clean, they're easy to understand, and they're a great tool to help you build your spreadsheet of activities. MSSP facts and what changed there are available. I have a link here to AAMC's summary on their advocacy for the proposed rules and all of that. if you go to AMA or HEMA or any of these sites where maybe you're not a member, there's a lot of free resources related to the public health emergency. I highly recommend that you start building a reservoir, build a folder, and download resources, because upon the expiration of the PHE, many of these are going to revert back to being member-only resources. So collect that bank now, so that if you were audited and somebody asks, why did you do this way? You still have the material that you referenced once upon a time as to why you put those policies in place, right? You put yourself in a defensible position in terms of an audit. And then last but not least, make sure that you speak up. So as I mentioned, I'm on the Government Affairs Council for MGMA. We talk to members on a regular basis. We seek surveys, we ask for insight, and we give that information back. The most important thing, and the thing that gets legislation changed the fastest, is your actual stories. So when you say, hey, we would love to abide with this, but we can't because in our state, this is what happens if we do that. Or we have patients who can't receive care because of X. It's those stories that take our legislation and our ability to change legislation the furthest. So if you have something that's really going to impact you, or something that's particularly painful, or a specific scenario that tells a story in a way that is really powerful, please send that to Government Affairs. All you have to do is email govaff@mgma.com. We want to help make your lives easier. We just need those stories in order to do it. If you're looking for additional industry resources, they are everywhere. I've got links for you everywhere. If you want to listen to me and Kim drone on about revenue cycle management changes there, dial into our podcast. CMS has information, Becker's Health. MGMA is my go-to resource for most everything. Not just because we wrote a book for them, they were long before that. MGMA is focused on practice managers and giving them the resources they need, but always have more than one source of information. So check out Healthcare Finance, check out IHI, right? Check out AAPC, and make sure that you're getting all of those resources that you need. And again, if you have any questions, please reach out to me. I want to be here to answer questions for you as much as possible. So yes, Kim and I both consult, but we consult on projects and we're busy. We are very, very busy. We are not billing people for one-off questions. If you have those questions, please ask them. We want to make sure to help out. I feel like that collaborative spirit that everybody had during the pandemic, and everybody was surprised that healthcare picked up so quickly. Healthcare, and those of us who work in it, we're not surprised. It's always been a collaborative effort, and we want that to continue. So with that said, I'm going to pause here so that we can talk about it, answer any questions. Feel free to turn your camera on and make Peter happy. I'll go ahead and turn mine on. If you have questions or you want me to go back to a slide and talk about it, now's your time. So any questions on the public health emergency, or is everybody just like, great, we've got another whole thing to worry about now?
I have a real quick question.
Yeah.
Telehealth. Out of our providers, I only have one physician that does telehealth. We're a specialist office, so generally it doesn't, we never did it prior to the pandemic, but
Sure.
So you're stating at the end of the PHE, telehealth will only go for behavioral health, correct?
Yep. And this, remember, this is Medicare. We don't know what commercial payers are going to do, but for
Okay.
Medicare, yes, that's the case.
So let's say it ends on December 31st. So December 31st, it's telehealth goes away. Now I thought you said she could do audio, or no?
So all of the things that remain are going to be for mental and behavioral health.
Okay.
Only. And let me pull that slide back up here if I can find it really quick. It's going to be for mental health only. There is audio only. It requires a modifier, that FQ modifier. That's audio only if the patient requests or the patient doesn't have video capabilities.
Yeah,
They're very specific.
Okay, we're not mental health. We're PM&R. We treat amputee patients as well. So she was able to do telemedicine with her amputee patients and treat them during this time for the last 2 years that way.
So I think that would be a great story to send into Government Affairs as to why telehealth should be available outside of just mental health services.
Absolutely, because they have a hard time getting around it anyways.
Yeah.
especially in the winter time when there's, 4 feet of snow, not 4 feet, but you know what I'm saying.
Oh, I know. Sometimes there is 4 feet of snow out here and in Pennsylvania. I grew up in
Absolutely.
Maryland, so I totally get that. Yeah, I mean, we have rural patients it's the same way, especially elderly rural patients. Even my grandparents are like, if I have to go back in there, I'm just not going to go.
And we have a lot of double amputees. We have a lot of individuals who are double amputees. So, it makes it very difficult for them to get around. So, those ones, we have got them on the video calls, and we just try our best to do calls with them.
Yeah.
Okay.
Kaya, sorry, does the licensure expansion for telehealth also go away for mental health?
Not for mental health. So mental health, they pretty much are keeping most of the expansions. So if you're in the mental health, telehealth, you're in a sweet spot. It's non-mental health that is seeing all of those flexibilities disappear.
So the patients that we have that moved to other states that we just kept seeing, we can still keep seeing even though we have nobody licensed in that state.
So if it's mental health, and you're still going to want to look, I would still look at the interstate licensure compact to make sure you're complying with that. But remember that there are in-person requirements. So if it's a new patient, you'd have to see them within 6 months of that visit, and you'd still need to see those patients every 12 months.
Right.
To remain in compliance. So if they moved way to another state, they're still going to have to meet those in-person requirements somehow.
Right.
Anybody else? I would tell you, every time one of these rules comes out or something changes, we just bang our head into the desk. When the proposed rule came out and they didn't expand telehealth for everybody, that really MGMA's Government Affairs Council said, does anybody want to talk about this yet? Or does everybody need a minute? And everybody was like, we need a minute. We need a minute. Because some of the things that happen seem so completely out of touch with what we need in the industry. But it's just because they don't know. They just need those stories. They just have no idea what you guys are dealing with day to day. So I like to think of it like, send all of your complaints. What do you hate right now? What is driving you the most crazy? Tell us, and then let us go fight the good fight for you, right? So like, we got everybody a couple of years ago to really just ramp up on prior auth, and things take a long time, right? They always take a long time to change. But a couple of years ago, we got everybody really vocal about it. And now we're finally seeing traction, right? And the House just passed like yesterday, some legislation that will help us on timely access to care and things like that. So it does take time, but you are making a difference when you complain about the stuff that's driving you crazy because they just don't know. I can actually give you guys a specific example. So Kem is my partner in crime. We usually present together. When Kem and I were both in Maryland, Blue Cross and Blue Shield at the time, Care First, wanted to put through a policy that all providers had to update their demographic information in Blue Cross and Blue Shield system every 30 days, and every other insurance company every 30 days. And it was this huge battle. They had their national legal person there debating, and Kem and I were there because we were on government affairs in Maryland. And we were trying to explain like how ridiculous it was, and they didn't understand. So the senators, the delegates, they're all like, I mean, I think it's reasonable that the payers want updated information. And finally we said, you guys realize that providers don't hop practices like retail employees. Like there's credentialing processes and all of this. They're not going places every 30 days. And even if they were, why can't the payer go out to CAQH or somewhere else to pull the most updated information for our providers as opposed to us doing it? And they were like, oh, we didn't realize that. Yeah, that makes way more sense. Okay, no, Care First, we're not going to do your thing. Their thing sounds way easier. And that was it. Bill got knocked down and never got brought back up again. And that to us seemed so common sense. We're like, how did this even get onto the docket? But it's just because they don't know, right? So your stories make a huge difference. If you have them, please send them. Especially, Heidi, the situation we were talking about. I grew up in PM&R, so I'm with you. No, I know I'm with you guys. Now is a good time. Whenever we talk about legislative stuff, it's a good time for either a cup of coffee or a stiff drink, right?
Mm-hmm.
Yeah.
Michelle needs her wine.
We all do after we talk about this stuff. There's a reason that we have government affairs meetings super early in the morning, and it's so that everybody will drink coffee instead of alcohol. Yeah. Well, if you guys ever have any questions, any concerns, if you are a podcasting person, you ever want to listen to Rev Dive, we have a Spill from the Hill correspondent. Her name is Claire. She's the leader of government affairs at MGMA. And so she comes on every couple of months to just give you guys kind of the behind the scenes of what is actually going on, which is super cool because she's totally unfiltered and awesome. So if you ever have a super direct question and don't know who to ask at MGMA, let me know. I'll get you to the right person. And other than that, let's just all keep helping each other and make it less painful, right?
Absolutely. Thank you so much for your time today, Taya. It was very insightful, both sessions, and we will look for you at the national conference too. So,
yes, please.
Yeah, definitely. I will invite Shelley up next to talk and introduce our last speaker.
Hi, everyone. Thanks, Dave. I apologize. I would turn my camera on, but for some reason I appear upside down. So if you want to see me upside down, I'll turn my camera on, but you probably don't. And don't ask me why it's upside down. It's been the day. So our last speaker today is going to be Brian. And I do have a bio here. Brian Courtney began his career at the height of a difficult insurance market. Working with a large regional insurance broker, Brian served various industries in procuring insurance coverage for tough to place risk. He now serves as vice president at the Safeguard Group, where he is primarily responsible for the direction of risk management services for his clientele. Brian is also a great friend to the PA-MGMA group. He did serve on the past, served in the past on the board and was a speaker at prior conferences. He's not afraid to speak on difficult subject matters that impact any organization's total cost of risk, and we knew he could tackle this subject for us today. Please help me welcome Brian Courtney.
Well, as I was saying, and what you didn't hear is I always get asked to talk about extremely uplifting subject matters for you guys. So I try to do my best to take these rather sobering topics and make them interesting and you know, and not fun. Fun's not the right word, but you know, certainly, you know, try to bring some levity to the subject because it is kind of sobering. And workplace violence is certainly an issue in healthcare, which, you know, I'll certainly get into today's presentation. And the news of it is just not getting any better. And there are steps that organizations like yours can take to not only try to prevent issues from happening in the workplace, but in the event that something does happen, that you have a plan in place to ensure everybody has a safe exit from the business. So we're going to get into all the subject that revolves around workplace violence. I actually will tie it back to insurance because there are some insurance ramifications that you probably have not been made aware of. But for the most part, the subject is going to talk about the risk management strategies that you can implement into your practices. So without further ado, we'll get moving along here on this. So first, the objectives. The first is we're going to talk about the prevalence of workplace violence, specifically in healthcare. We're going to also learn the definition and types of violence and understanding your roles and responsibilities, not only in the preventative measures, but also in the reactive steps should a violent act begin to occur in the workplace. Also, we want to know how to recognize, report, and react to violence, as well as putting preparedness measures in place in the event of an emergency. And I'm talking specifically about active shooters. So just how bad is it? About 2 million American employees report being victims of workplace violence each year, of which 30,000 women report sexual assaults in the workplace annually. 1 in 7 people do not feel safe in the workplace. 60 million Americans feel like they're being bullied. 23% of employees say they've been bullied via email. And here are the true costs to organizations. You know, there is $130 billion lost every year due to workplace violence. And And then healthcare is really, really bad industry. I'm afraid to say. It leads all industries in the impact of workplace violence, with an average of nearly 13,000 non-fatal incidents occurring annually. If you Google right now, workplace violence in healthcare, you will get articles today that is talking about what's going on in healthcare and workplace violence. I challenge everybody on this call, just Google it and you're going to be amazed, like, wow, like this is fresh information. It is as of today, but 73% of workplace injuries in healthcare settings are due to violence. You know, and in June, just this year, 5 violent attacks in US hospitals. Nurses are the ones that are most at risk, and they were assaulted on the job in the second quarter, 5,000 nurses. That accounts to about 2 nurses assaulted every hour in the workplace. So again, really, really sobering facts about workplace violence in healthcare. And if you just go into the news, you'll see this on the news almost every day. It's tragic, the amount of mass shootings that we have, not only in healthcare, but other industries as well. So, you know, the one that, you know, that has been most recent and kind of, you know, and local to us was a healthcare worker walking into Jefferson University Hospital and fatally shooting another healthcare worker, co-worker. And we tend to see that. We tend to see, you know, co-workers shooting each other, but it also could be coming from patients or just visitors in general that have no business being in our environment. So moving on, we're going to talk about defining workplace violence and understanding it and understanding the warning signals. So what is workplace violence? It is an act or threat of physical violence, harassment, intimidation, and other threatening or disruptive behavior that occurs at the work site. So it happens within the 4 walls of your business. I talk a lot about harassment. I talk a lot about bullying. That all encompasses workplace violence. So not only are we kind of concerned about like active shooter events, because those are the worst case scenarios, but we also want to try to eliminate any type of harassment or bullying behavior that can cause a hostile work environment, because it has deep implications on employees' safety and health and overall productivity within your offices. It can range from threats and verbal abuse to actual physical assault, up and including homicide. So just know that it involves everybody, not just employees, not just your patients or clients or customers or vendors. It could also include your visitors in the workplace. So what causes, you know, what are some of the risk factors that cause workplace violence to occur? First, any business that is associated with exchanging money with the public, they tend to be targets of criminal activity and violent criminal activity. That doesn't necessarily apply to healthcare settings, but it could. So just knowing any type of exchange with money could lead to a violent episode. Working with volatile or unstable people. I'm sure all of you at one point in time have had to deal with a distressed patient at one point in time. And there are certain things that we're going to talk about to help you de-escalate some of these scenarios so they don't turn into a more violent act in the workplace. If you're working alone or any isolated areas, this too could also contribute to potential violence in the workplace. The thing that I think I always try to stress to my medical practice clients, specifically when you get into the kind of the winter months where it starts getting dark at 5 o'clock, is walking to your car, you know, after dark. You know, these are situations that could leave you prone to a violent act because you're not necessarily seeing a perpetrator that can come and attack you. Years ago in my hometown of Coatesville, where I grew up, and at a YMCA that I used to go to when I was a kid, they had a workplace violence incident that occurred at 5 o'clock in the evening during the winter months. It was involving one of their employees who was going there to instruct a class, an aerobics class, and she was approached by an ex-boyfriend, a disgruntled ex-boyfriend, who shot and killed her on site and also shot and killed himself. And this led to a lockdown of the facilities. It obviously concerned everybody involved. And, thankfully, there was nobody else injured in that incident, but it was a horrible, horrible situation. And again, it happened in a situation where she was isolated and alone in a dark area in the parking lot, and never saw it coming. So again, working alone in isolated areas may contribute to potential violence. Obviously, any type of, providing services and care, that's all healthcare is, right? It's service and care to others. People may feel like if you're not providing the right level of care, this could frustrate them to the point where they may act violently towards you, either verbally assaulting you or physically assaulting you. Any type of place of business where they're serving alcohol or any other type of pharmaceuticals, this could lead to violent acts. And then working late at night or areas of high crime rate areas. These two are risk factors that healthcare organizations need to consider when trying to mitigate this risk. So there are 4 different types of workplace violence. The one that is pretty standard is the criminal intent, where the perpetrator has no legitimate relationship to your business or its employees and is really just there to commit a crime in conjunction with the violence. And that's typically like any type of robbery or shoplifting or any type of trespassing. That's criminal intent. But what you may see more in healthcare is kind of that customer patient or customer client relationship that could lead to a violent act towards one of your employees, or on that worker, which is, it could be what we call lateral or horizontal violence. This, again, it can include bullying, and frequently it manifests itself into verbal and emotional abuse of another individual. And what often starts as bullying could actually lead to illegal harassment, and even that illegal harassment can also lead to sexual assault. So if it's not dealt with properly in the workplace, it could lead to something much, much more severe in the workplace. And then the last is kind of the personal relationship, right? The perpetrator has a personal relationship to the victim outside of work that spills over to the work environment. The example that I shared at the YMCA, that was a personal relationship that spilled into the workplace. So these 3 things are pretty prevalent in the healthcare setting. So, do you have a responsibility? Yep, you do. OSHA states that employers must take precautions to identify, minimize, and prevent the risks of workplace violence. Just know, employees have a right to a safe workplace that's free from recognized hazards that are likely to cause death or serious physical harm to employees. That includes violent acts. So again, it is not only a moral requirement, but it is also a regulatory requirement as stated by OSHA. So how can we prevent an incident from occurring? If you work with any type of high-risk clients that are prone to violence, you have to have a plan in place and take extra precaution when those individuals are on site. You need to know the warning signs of violent behavior. And at all times, you should report any type of the following: any type of verbal or physical harassment, any type of verbal or physical threats, assaults or any other type of violence, and any behavior that causes you to feel unsafe. That includes bullying and harassment. You need to report those matters to the appropriate people within your office. And just like harassment and just like bullying, you should provide multiple channels of support for your employees. the reason why we want to provide multiple channels of support, and this should be in your employee handbook. And if you don't have an employee handbook, you need to get one, and you need to advise your employees of where they can go to get help. The reason why we provide multiple channels to support is because we do not know who the perpetrator could be. If you said, hey, you need to report all these matters to your HR department. Well, what if your HR director is doing the harassment or doing the bullying or acting violently towards another individual? You don't want the victim to have to then go to the perpetrator to go to get help. So again, we want to provide multiple channels of support for employees should they be a victim. And that's also true for witnesses. You don't necessarily need to be a victim. You could witness this behavior, and you should cooperate with the employer to make sure that we're creating a safe environment. So that is your responsibility as an employee, and it's also your responsibility as an employer. So what are the warning signs of violent behavior? You got to take note of your customers or coworkers' behavior patterns. If they're changing rapidly, if their behavior is disrupting the work environment, and I'm saying disruption in a good way, and not in a good way, in a bad way, or you see elevated signs of stress more than normal, these are all the early warning signs of violent behavior. And what could that look like? It could be as simple as changes in attitude, and I've listed a whole host of them here. The one that people go, really? Poor hygiene? That's a warning sign of violent behavior. Well, when I was giving this presentation years ago, an audience member said, you know what? I work in a healthcare setting, and one of the patients that I treated said, if I do not shave or brush my teeth in 3 days, you should know that I'm not in a good state of mind. They basically was pointing out the fact that their poor hygiene was a warning sign of potential violent behavior. So again, some of these things are kind of intuitive. Yeah, like, any type of fascination with weapons or violence, or if there's a history of violence, or you're increasing the use of drugs or alcohol. Yeah, those things could be warning signs of violent behavior. But there's also some things in here that are kind of more subtle, that you should also consider as part of the warning signs of violent behavior. Now, I say that not all these warning signs will lead to violence. Warning signs could be just normal changes in mood. We've all had bad days, right? We've all had days where we don't feel like we're not feeling it today, right? Or something may have happened in our personal lives that's making us sad, right? Those things happen from time to time, and they could change our personality. There's no doubt about that. So, drastic changes in personality or changes in situations, they could bring out violent tendencies, but they don't always. So before you report, I always say, just keep in mind, use your best judgment before reporting issues to your supervisor, okay? So what are some of the nonverbal cues of potential violence? Anybody that's violating your personal space, or they're talking really loud, or they're breathing kind of rapidly or shallow, and any type of abusive language, where they're yelling and screaming, they can't make eye contact with you, or they're sweating, or clenched jaws and fists, trembling, shaking. These are all nonverbal cues of potential violence. And this could be not only patients, but it also can be employees. So what techniques can we use to potentially de-escalate employees or patients that are in distress? The first thing I would recommend that you do before you do anything, there's really two things. Number one, before you go into a situation where you're trying to de-escalate a situation, you need to have a plan in place to protect yourself. And I don't mean, you need to arm yourself, with a weapon. What I mean by that is you need to look at your situation, that your surroundings, where you are in relation to that person. So in the event that de-escalation doesn't work, you have a plan in place to escape and to get out. Okay, so that's first and foremost. The second thing, and this is really the most important thing, anytime you're getting into a situation where somebody's in distress and they're acting angry and aggressive towards you, you need to calm yourself first before interacting with them. All right, you need to get a few moments of time, take deep breaths, and understand you need to remain calm at all times. And that involves really becoming aware of your situations, your surroundings. Where are you in relation to them? Are they standing? Well, if they're standing, you should stand. If they're sitting, you should sit. Where are your hands? Are you making eye contact with them? You have to try to appear non-threatening as you can, knowing that you're being open and you're willing to listen to them and listen to their concerns. You have to show empathy, even in the face of somebody screaming and hollering at you. Again, your job is to remain calm and to understand where they're coming from and why they're so angry. If possible, make a personal connection. The best way to make a personal connection is to call them by their name. If you don't know their name, ask them their name. And when you're addressing them or talking to them, continue to use their name. When people hear their name, they feel a personal connection to the person that's saying their name. I don't know the psychology around it, but people love to hear the sound of their name. So the more times you can make a personal connection with them, the better the chance you have of de-escalating the situation. Again, as a person who's now listening to their personal concerns, you want to bring them into whatever the solution may be, and shift the conversation to the future and create hope for them. They're obviously angry. They're really upset. You care about the reasons why they're upset and you want to help them. That's the overall message that they have to get to. And then once you start uncovering things and understanding where they're coming from, start getting agreement from them. Get them to say yes. It's really hard for somebody to continue to be angry with you if they are agreeing with you and they are saying yes. If they are not agreeing with you and you are not agreeing with them and you are saying no, that's only going to escalate the situation. So again, the more you can get agreement, the more you can get them to de-escalate, the better chance you have of lowering their stress levels and keeping a violent incident from occurring. Now, despite all your best efforts, if it's not working, just stop. Don't continue. Don't continue to try. And more importantly, if at any point in time you feel unsafe, you need to leave and you need to call for help. That's really important. I'll stop there for a second. I'll open it up to any questions and then we'll continue on in the conversation.
Are there any questions for Brian?
I love doing this in person, guys. So if we can try to make this as interactive as possible, that would be great. If not, I can continue.
I'll bring Peter back if I have to. You know he'll make you. You should have seen them, Brian. They were chatting and asking questions. So
Yeah.
they were everybody was chatting. So if anybody has questions, now is a good time. But Brian will make time at the end as well. I'd go ahead.
All right. Oh, Heidi, you got
Yeah,
something?
well, this isn't a question. I'm just going to put this out as a statement. We have seen an uptick in the patients being more violence, more hostility towards my staff, whether it's on the phones or in person, to the point where I've had to train staff on de-escalation techniques, putting protocols in place where internal doors are locked now. The sliding glass on the front screens had to be closed at all times. It's a shame. It's a different world we're living in right now. One of my offices, a patient brought 2 guests with her. They sat in the waiting room. They walked across the hall and robbed the practice next to us. That was about a month ago. So it's just been very strange lately.
Yeah, and Heidi, thank you for sharing that. It's important that people understand that how close these things are to us, because the natural reaction is that won't happen here.
Yeah.
It's not, like that happens in other places. It doesn't happen here. And what we're finding is it could happen almost anywhere. And, not having a plan in place and not taking the steps that you took, Heidi, to better protect your staff could ultimately lead in disaster. So kudos to you and your team for recognizing those situations and doing your best to help de-escalate these situations.
Thank you.
You're welcome. All right, well, I'm going to move on. So we're doing pretty good here on time. So let's move on. So what is causing all these things? Obviously, stress is the underlying factor here. And I'm going to talk about stress, and this is really specific to your employees, even though, patients, as Heidi mentioned, could be the ones that are the aggressors or the perpetrators of violent acts. Employees could also be, the perpetrators of violent acts. And a lot of times it's triggered by their stress. And if you think about stress and what it is, it's a natural defense, body's natural defense against predators and danger. And it flushes the body with hormones and prepares the system to evade or confront danger, right? And we all know this is the fight or flight mechanism. And it triggers increase in heart rate and muscle preparedness and all these other things. And the more stressors we experience, the more stress we tend to feel. And that's where that fight or flight mechanism comes in. And what we don't want it to be is the fight mechanism that comes in, and then it takes it out on the rest of the staff. So there's a lot of things that people, bring to work every day, right? Some of the things you can't control. You can't control their family problems. You can't control illnesses in their family, or, a lack of love or companionship with others. There are a lot of different things that could ultimately lead to stress, and those stresses are coming into the workplace every day, right? So you have to understand that you can do all your part to create a safe environment, but just know that the employees, when they go home, they're going and they have these situations that are happening at home. They are bringing that back to the workplace, and these stresses could lead to a lot of the things that we talked about, which is violent behavior. So what are the symptoms of stress? There's obviously the physical symptoms, the sweating and the heart disease and muscle aches and difficulty sleeping and high blood pressure, fainting, lower immune systems, headaches, spasms. Again, stress can manifest itself in the physical, but what we also see is it manifesting itself in the emotional, right? Which is that anxiety and that depression, and then the anger, and the irritability. These can then lead to really, really poor behaviors. And those behaviors sometimes manifest itself into self-destructive behavior, right? Which is like the eating too much or too little, or drug or alcohol abuse. But then it can get into even worse behavior, like social withdrawal, frequent crying, and then the relationship problems start. And then the last thing that it could happen is the violent behavior towards themselves or others in the workplace. So what can employees do to make sure that they're managing their stress levels? And what is your role in helping that take place? Well, it goes without saying, they have to take better care of themselves, right? There's, if they're exercising more, they're taking less caffeine, drugs, or alcohol, they're watching what they eat, they're making time to get relaxation and time to decompress, and knowing what stresses them out. Let's be honest. Healthcare is a very stressful environment. And if they have stress at home and they have stress at work, it is a bad recipe for employees, and it can ultimately lead to violent behavior in the workplace. So we want to give employees the tools to take better care of their health. And how can we do that, right? So there are employer-sponsored resources that you can provide to your employees and direct them to so they can better manage their health care. So the first one is an employee assistance program that is offered by most of the, like if you guys are offering a benefits program, if you're providing like group life, short-term and long-term disability, oftentimes they will tack on at no cost to the organization an employee assistance program that allows an employee to get the mental health resources that are available to them. So that's number one. That's an easy resource that you can give to your employees so they can better manage their stress, so it doesn't turn into or manifest itself into a violent act in the workplace. The second one is workplace safety or wellness programs. Again, if you're offering any type of employer-sponsored health plan, the carriers, whether it be Blue Cross Blue Shield or Aetna, may provide certain incentives for employees to exercise more. They may provide some nutritional resources for the employees, so you can help provide them that piece of information so they can better manage their health. In addition, the physician groups that we work with, they also will put together a safety committee that talks about these safety topics, and then that information is then dispersed to the rest of the organization through the committee. So the employees themselves are looking at their individual workspaces and saying, how do we make this safer? How do we create a safer, healthier environment for our employees? So they're bringing those suggestions to the committee, and then the committee is then talking about those issues and then sharing that with the rest of the organization. So again, you may have employer-sponsored resources right now that can lower the stress levels of your employees, which in turn will reduce chances of workplace violence occurring in your workplaces. Think about it. Free resource, just easily communicated to the staff. It shows that you care about your employees and that you want them to be in a safe and healthy environment always, whether it's in the workplace or at home. That will reduce the chances, that will help them reduce their stress levels, and it will ultimately reduce the risk of a violent act occurring at the hands of an employee. All right, now we do a lot. We're doing a lot. We're trying our best to protect the organization from a violent act, but it could happen. Despite our best efforts, we could be we could be in a situation where there's an active shooter on the premises. And we need to know how we're going to respond when an active shooter is in the vicinity. So this has been discussed with every healthcare organization, and they try to simplify it for good reasons, right? Simplifying things makes it easier to remember, so you can then follow the steps in a crisis situation. And those 3 steps are in this order: run, hide, and fight. So we're going to talk about each of those specifically and the things that you need to do and why you need to do them in that order. So run. The first thing that all organizations should do is develop an escape route for employees in the event of an active shooter. You individually need to have an escape route in mind before the event, because once the event happens, you need to be able to say, I practiced this, I know exactly where I'm going. The second thing you need to do is to, when an active shooter is on the premises, leave everything behind. You do not need to pack up your workstation at that point. All right, leave your belongings behind, and then keep your hands visible at all times. Why should we keep our hands visible at all times? This is the interactive part.
I mean, is it to show that you don't have a weapon yourself in case like police or someone else comes into the situation, or?
That's exactly right, Melissa. You may be in a situation where you're trying to run and the police officers are on site at the time, and you want to be able to demonstrate that you have nothing in your hands and you're not one of the perpetrators of or one of the active shooters. So keeping your hands visible so that you're not mistaken for the person that's committing the violent act. That's first and foremost. Second, hide. You need to hide in an area that is if you can't run. This is only if you can't run. You need to hide in an area that's out of the shooter's view, and you need to block entry to your hiding place and lock the doors if you possibly can. Now, if you cannot run and if you cannot hide, you need to fight. Fighting is the last resort and is only used when your life is in imminent danger. You need to try to incapacitate the active shooter, acting with aggression, and throw items at him. So you need to use anything at your disposal to help that occur. So again, the first thing you should do is you should run. The second thing you should do is you should hide. The third thing you should do is fight, in that order. Don't try to be a superhero in these situations. Now, let's go back to the first slide. The question I would have for the group is, should you try to get others to follow you and lead people out?
Brian, this is David. I'm going to say no. I think you need to move quickly.
Okay. David, thanks for sharing. Anybody disagree? Okay. David is right. Okay. Now, and I would say you're 75% right, Dave. So, of course, if there are people that you can help usher to safety, try. If they're not following, get out. You're no good to the situation, trying to help everybody out before yourself. Now, the reason why we recommend that you get out, before helping others, okay? You can try to help others, but you should get out as quickly as you possibly can, is somebody needs to go call for help. Well, if you're waiting for others to join you, you might not be around to call for help. So if you can get out to a safe place where then you can make the important phone call to help others, because really we need police officers. We need trained professionals to deal with the situation. You getting out and making that phone call is the most important thing you can do. So, keep that in mind. Get out. If you can help others, great. If you can't, move on. Get out. You're going to best help them by getting them the help that they need. That's number one. When hiding, what are some things that you should consider when hiding? Outside of what I just shared, which is hiding in an area out of view and blocking entry to the doors.
Turn off the lights if you're in a room.
Yep, that's one.
I mean, I guess if there's a door, you could lock the door, if there's a door in your room.
Yep, lock the door. Yep. I'm waving something. Can everybody see this?
Oh, your cell phone, make sure it's like
Make a
silent.
call.
Yeah. I've appreciated everybody being silent on this presentation. But this thing can buzz and bing like nobody's business, right? So I always say this, and that, like, when you listen to these presentations, they're like, and when you're hiding, make sure your cell phone remains on silent. I say, make sure your cell phone's silent now, because you're not going to remember that when people are shooting and all that other stuff. You're not going to remember, oh, you know what? I need to remember to turn my cell phone down. And you're not going to remember it. So I always recommend to staff, keep your cell phone on silent when you're in the workplace. There's no reason to have it loud, okay? And if you miss a call, you can call them back pretty quickly. It's not a big deal. But if that thing buzzes and bings and alerts the shooter to your location, you're gonna regret it, obviously. So I always recommend keeping your cell phone on silent in the workplace. And I would say, as leaders of the organization, you don't want employees on their cell phone anyway. So make it a part of the cell phone policy or the bring your own device policy if you have one. So, responding to the law enforcement, remain calm and follow the officer's instructions. And I said this before, raise your hands and spread your fingers. Show them that you are not a threat, and keep those hands visible at all times. Try to avoid making any type of quick movements towards the officers. Know that they are also on edge here and that they're responding to a crisis situation. So anything you can do to avoid putting further stress on them is important. Avoid any type of pointing or screaming or yelling. You're only drawing attention to yourself. And don't stop to ask the officers for help or direction. Get out. So when you do get out, if the officers are not on site, you need to provide law enforcement information, location of the active shooter, the number of shooters, if it's more than just one. If you have a physical description, if you saw them, share that with them. What type of weapons do they have? And have there been any potential victims at the location? These are all things that you need to share with law enforcement. So, any type of situation where there's a post-incident accident, you know, you need to do an analysis, you know, and you have to really, you know, as painful as it may be, you have to talk about the warning signs. Hey, did we miss something here? How did this person enter the facility? Were they granted unauthorized access? You know, how quickly did we alert authorities? And, you know, were we able to usher our customers and our employees to a safe, you know, environment? Did everybody follow the plan? Did it work as intended? And did we keep everyone safe? And then what can we do moving forward, you know, to better discourage violence occurring in the workplace? These are all things that you should do post-incident, should it happen in your workplace. So then I get the question as an insurance professional, like, hey, is workplace violence covered for, you know, is there insurance coverage for this? In short, the answer is yes, no, or maybe. It depends. And, you know, I can cite some specific examples. Specifically, let's talk about commercial property insurance, right? Let's just say you have an active shooter event and, you know, you have some physical damage to your space. And certainly a workplace violence incident would cause a disruption in your business, a shutdown in your business, maybe temporarily, because you're dealing with a crisis situation. Well, this is where the commercial property policy is limited, because you're saying, well, I have a business interruption claim because my business was interrupted due to a workplace violence incident. I can't go back to work because people don't want to come back to work just now. They're traumatized. Or, you know, my patients don't want to come here because they're traumatized. Well, the reality of business interruption claims is that it will only cover any loss of income and extra expense that you may incur due to the suspension of normal operations during the period of restoration. So, for example, if you had a workplace violence incident where it caused some property damage to your site, but you were still able to technically operate out of that site, you don't have a business interruption claim. Yet you might not be able to return back to work right away. So again, there's limited coverage under the commercial property for a business interruption. And that same can be true for general liability. Any type of crisis situation involving patients, or if they could say, you created a hostile environment for me, therefore I'm suing you for negligence. Well, you better hope that your general liability policy or your medical professional liability policy doesn't exclude workplace violence incidents or limits it in some way where you feel like you're not covered. So again, just be mindful of that. Same thing could be said for the crime coverage. You know, sometimes violent acts may not be covered by a commercial crime policy. Same thing with workers' comp. Think about it from this perspective. Workers' comp covers employees that are injured on the job. Well, let's just say an employee didn't suffer a physical injury, but they suffered emotional distress. Is that technically comp? Certainly, the stress came from an incident that occurred at work, but there was no physical injury to the worker. So there's a potential that that type of claim might not be covered by your workers' compensation policy. And then last is employment practices liability. Employment practices liability it covers the harassment, wrongful termination and discrimination in the workplace. But let's just focus on harassment. Harassment may exclude any type of assault on the policy. Now, some policies for employment practices liability will cover workplace violence incidents, but they typically will provide a sublimit of coverage. So they're not providing the full limits, and they're only covering specific things with workplace violence incidents. So again, you could have a situation where you have a workplace violence incident and you're looking to your insurance policies to provide you protection, because you're going to suffer not only the emotional loss, but you're going to suffer some sort of financial loss as a result, and your policies may not respond to you. So there are policies out there, I can tell you, not one of my clients buy this coverage right now, not one. It's not, and we do talk about it, but again, I think the perception, like cybersecurity insurance was years ago, it's not going to happen to me. It's not going to happen to me. I'm not going to buy insurance for that. And I get it. Nobody wants to think that a violent act is going to occur in their workplace. But it could. And if it does, you just need to know what you're covered for, so you're better prepared in the event of a financial loss. So these are not fun topics to talk about, but hopefully you learned some lessons here to prevent violence from happening in your workplace. I'll open it up to any questions, but I would direct you to a couple resources that I used as part of this presentation. Certainly the OSHA has some good guidance on how to prepare for and how to create a safe environment from violence, as well as the Department of Homeland Security. So I would recommend that you would go to both of those sites to see what steps that you can take to create a safe work environment. That said, I'll open it up to any questions, comments, or concerns.
Brian, this is Dave. Question about social media and, what you can, what you can react to, what you can't react to. I mean, if you think someone's a, little edgy and you're getting nervous, and maybe that's more of a legal question, but I'm curious on when does that, when might that be something that you react to in terms of trying to mitigate risk?
So again, I think there's a couple qualifying questions if I could. So it's an employee that is that you may be connected to on social media, and they are acting strangely on social media, maybe having some level of fascination with violent behavior, or
yeah, I'm thinking an employee says, "Hey, I got on Joe Schmo's webpage, and he said something outrageous, like if anyone voted for politician X, they should be shot." So probably a rhetorical statement, but this is the kind of stuff that percolates up sometimes.
Yeah, and people are deeply passionate about politics these days. What I've found is like they, you're and so passionate that they are, the rhetoric has been somewhat violent, aggressive, behavior, and the posts are somewhat puzzling to me. I would go back to the use of common sense, but if you did see something and somebody's reported something to you, I think you have a responsibility to respond to that. So if two employees are on social media and one employee says, can't, anybody that votes for this guy or votes for this lady should be shot, and they feel somewhat threatened by that statement, yeah, you have an ability to respond. And you know, that's one where you just bring the person in and say, hey, you know what, you know, I know you represent yourself and your own political views, and that's fine, but if you're causing, you know, people to feel unsafe with how you act, you know, I have the responsibility to make sure that we are in a safe environment where everybody feels safe and respected. So I don't know if that answers your question. I did actually have I had a personal situation kind of like that. I didn't feel at all threatened. But you know, I had an employee whose husband made a comment about Kyle Rittenhouse, who's the teenager who was tried for murder and acquitted at a violent protest up in the Midwest region. And I just shared with my employee, I said, you know, and it wasn't her post, it was her husband's post, but I happened to be connected to him. And I just shared with her, I said, you know, he could certainly post about what he wants, but that could potentially boomerang back towards you and you know, if he's connected to others at work like that. So yeah, she actually appreciated the heads up, you know, that that probably wasn't the right thing for him to say or do on social media. I wasn't mad at him. I just as a courtesy, I said, listen, you know, you probably didn't mean it the way it came out on social media, but people could misinterpret that, and you know, you just want to be more careful about what you post.
Thanks.
Yeah, but that's a great question. It's a hard one to answer, but it's a great question. Wasn't everybody supposed to show their faces to me, Aaron? Like now that we're done the presentation.
Yeah, they're not following the rules.
Oh, there they are. Ben, but you got to turn your microphone on. So
I'm still here,
Brian.
Brian.
oh, there you are. It's nice to see everybody's faces again. I wish I was doing this in person.
I'm still upside down.
Shelley's upside down.
Which means you really are upside down.
Shelley,
Maybe
I
you turn it around.
Why? I don't know. It's bizarre.
like, are there 101 Dalmatians where you're working right now?
Well, can I call them monkeys? No. I have no idea why it's upside down. It was not earlier today, so.
Make sure you wash your hands.
I told Shelley it's the perfect metaphor for
It is.
for life today, right?
Yeah.
That's
Yeah,
right.
my day's been upside down. Yep. Mhm.
Well, you all have hung with us very well, and I thank you very much. Thank you, Brian, for your expertise. Does anybody
Thanks,
have
Brian.
Yeah, you're welcome.
any specific questions or discussion they'd like to have around Brian's talk?
By the way.
Hi, Brian. Yeah.
Thanks,
good to see
Thank you,
you.
Brian.
Shelley, you want to take us out?
Sure, absolutely. I just want to thank everyone for hanging out with all of us today. And we had some great speakers, lots of information. Just a reminder, next Friday, there is a webinar on revenue cycle management, ways to incentivize your staff. It sounds kind of exciting. So I encourage all of you to register for that. And if anybody else doesn't have anything, thank you again and have a great weekend.
All right.
Thank you, Shelley.
Thanks,
Thank you,
Shelley.
everybody. Good to see
Bye-bye now.
everybody.
Everyone, have a good
Thanks,
weekend.
Brian.
Thank
Bye-bye.
you.
Thank you.